I will introduce our first speaker tonight. Actually, he is a great topic, great speaker, but I'm sure a lot of people are going to miss it. Dr. Sheikh is with us. He is going to speak on neuromodulation in 21st century, machine meets mind and brain. As you know, this conference we focused more on either the cutting edge, new things. AI has been an important topic in everything in our lives. So this is very, very important for us. Dr. Sheikh is actually the Vice Chair for Research in the Department of Neurology in University Hospital Cleveland Medical Center. He also runs a lab on motor lab, which is in the Louis Stokes Cleveland VA Medical Center. He's also associated with Case Western Reserve University Cleveland. So he has a very strong academic career and lots of research being done.
So thank you everyone for having me this morning. I work for the federal government, I work for the Department of Veterans Affairs, and I want to start off with the story of a 46-year-old U.S. Navy veteran who happens to be my patient as well.
Shortly after that, I started seeing the symptoms of Parkinson's. I ignored it for a couple of years. I would love to be able to walk without a cane. That would be awesome.
It's Sunday night in Cleveland, Ohio, and we're broadcasting live from OR 23, an operating room at University Hospital's Case Medical Center, where right now a team of doctors is performing brain surgery. And if that isn't remarkable enough, here's another detail. The patient they are operating on is awake. The patient is a 49-year-old Navy veteran named Greg Grinley. He has been diagnosed with early onset Parkinson's disease and as a result suffers from severe tremors. The hope is that as this surgery continues over the next 2 hours, his life will be improved and transformed.
I'm going to turn it on now. Left,
August,
right.
July. Turning it on. Here it goes. And the tremor's gone. Provide dry goods, canned goods, meat, and just about anything else you can think of. This is for the weekend. Milk, cereal, canned goods. Yeah, I love the fact that people are volunteering now because it's Christmas and Thanksgiving season. What happens when Christmas, Thanksgiving are over? Kids are still hungry, people are still hungry.
How long have you been doing this?
3 years. We went from 50 families the first month, we average 350 families a month now. That's not people, that's families. Surgical staff, everyone was beyond nice. I was expecting a lot worse, a lot more trauma, and it wasn't there. It didn't happen. I was in the hospital 24 hours. And for the brain surgery, I literally went in at 2 o'clock one day, went home at 2 o'clock the next day. I just wanted to be able to enjoy my life, you know? So, retired as a Navy chief at 38.
So this is Parkinson's disease, right? It's more than abnormal movements. And now, very recently, last week, Greg told me that he wants to ride motorbike. I said, no, you're not doing that. You're good, but not motorbike. Anyways, but it's more than movements. And a lot of times what we see is that it disrupts your perception, your action, the way you perceive what is around you. You perceive your own movement, it's gone. And it actually affects your reaction time. It impairs your visual and spatial navigation, how you navigate around, how you walk around in this hotel, how you get to this hotel. And it then heightens a lot of depression and anxiety because a lot of things that you could do, you cannot do. So it's a big problem. We are very much focused right now on how to fix tremor, how to fix gait, how to fix walking, but this is a significantly important problem in addition to tremor and walking. And that's what we are going to talk about today. How we can modulate the brain in general, and particularly starting off with Parkinson's disease, to modulate mind, to modulate your cognition. How we can use deep brain stimulators to change your executive behavior, to change your visual spatial navigation ability. The work comes from VA and federal government, and I'm also affiliated with University Hospitals and Case Western Reserve. Moving around you pretty well and there is no rush. But before you know, the traffic starts, right? Like everybody's moving around you, one car is coming from one side, the other one is coming from the other side, and the real haywalk starts, right? Normal person, healthy person, can take care of all this self-movement, movement around you, cluttered environment, everything very well. And their brain can handle it quite well, but people with Parkinson cannot. What happens to them when you put them in a cluttered environment, busy traffic, busy room? They tend to freeze, they tend to fall. They cannot process their movement around them that well, and that is a significant problem with their quality of life. So what our work is basically to study how Parkinson affects your visual and spatial navigation, and there are two aspects of it. One is perception of your own movement, how you are moving in your environment, and how things around you are moving in respect with you, and how you combine the two and ultimately navigate through your daily routine, right? And the fundamental question is how we can modulate this behavior with a little electrode which sits in the brain connected to the computer which is in the chest, and me as a doctor tap into that electrode with my computer wirelessly to program your brain. So this is the whole idea of modulating your brain using brain-computer interface to modulate your visual spatial navigation. So that's the theme of our research, and that's what we are doing. So what we do, so first we will talk about perception of your own movement, okay? So in order to do that, we have a very unique facility in our laboratory. And you can see here on this slide, on the left side, with the perspective, this is me standing next to the machine. And that machine is almost like a flight simulator. It's akin to a flight simulator. It's called Hexapod. What Hexapod does, you can see that on the middle caricature there. What Hexapod does is it takes the person sits in there and wears a virtual reality goggle, and then the Hexapod moves the way we program the Hexapod. Okay, you can program Hexapod to land in Bombay, and it simulates the whole landing in whichever city you want. It can simulate your normal walking behavior. It can simulate as if you are in a race car. It can simulate whatever kind of movement you want. What we did, we simulated a normal movement that Parkinson person needs to make in order to get through their environment, which is walking straight ahead or going to the right side or going to the left side. And while they do that, they are wearing a virtual reality goggle, and goggle then shows them what they will see as they are going straight or to the right or to the left. So just almost like walking, but very highly controlled and very highly measurable perception of walking. That's what we are looking at. So we precisely, by this means, can measure their own perception, what they are perceiving as they are moving. And we can compare how Parkinson affects that perceptual behavior, how they're walking around, and compared to normal counterparts. And then we stimulate deep brain, using the deep brain stimulation probe, we stimulate different parts of the brain and try and figure out which area of the brain can change the way they perceive, right? So these are the three questions that we use with an electrode implanted in patient's brain. An electrode is on and off, and they are in the flight simulator. So this is kind of an experimental setup here. So you can see that person is sitting in the hexapod and seeing through the goggle. And first thing, I'm going to simulate like a regular traffic in New York. And what you see, the star clouds are moving, right? Like regular movement without any clutter. So that's one simulation condition where they're just walking in a star cloud, right? The second condition is a little bit clutter. So the same star cloud, but the clouds are moving in many different directions. As you can see here, that all these bunch of dots are moving randomly. They are not moving simultaneously, which creates a bit of a conflict. So you're moving straight in the simulator. Simulator is moving straight. Clouds are moving straight. It's straightforward, right? But if you are moving straight and cloud is moving all over the place, then your brain then is confused whether you're moving straight or you're moving around. And brain has to then figure out what is actuality rather than a conflict. And normal person, as you will see, can very easily sort out that conflict, but it becomes a problem in a brain disease. So how do we do that? So what we call two alternative force choice tasks, for example, right? So we give a condition when person is moving either straight or to the right or to the left, and star cloud is moving in that way with some conflict. What they have to do is they move to the left, then they have to click the left button, okay? If they move to the right, they have to click the right button. Very simple. Which way you are moving, you perceive that and you click that button. And when you move straight, they have to press either right or left, so they do 50-50% chance, right? So we create a probability. They have to go by the probability of which way they are moving. And if they are moving extremely to the right, you know that you are moving to the right with a full confidence. So more eccentric movements you have, very likely you are going to click that button almost 100% of the time. And you're not going to click the left button almost 0% of the time, right? So that creates a little curve. So this is the probabilities on y-axis. X-axis is the direction. If you are almost in extreme right, which is positive 30 on the graph, you are almost 100% of the time you are going to click the right button. But for that leftward movements, you are almost 0% of the time you are going to click the right button, right? So it gives you a nice sigmoid shaped curve that tells you if the curve is really steep and it has a good S shape, that curve tells you that person has a very good ability to perceive their movement. And the blue is when they are 100% conflict, and red is when they are 50% conflict. This is a normal person and they perceive everything very well. They resolve conflict very well. Now see what happens when I put a Parkinson patient here. So they cannot resolve the conflict. They cannot tell whether they are moving to the right or to the left as precisely as a normal person. So what you see here is that only 80% of the time they press the correct button, which way they are moving, and that curve is much less steep, which tells us that patients who have Parkinson's disease, they are not able to navigate through that precisely. So what did we do in the lab? We went in with the deep brain stimulator electrodes and we activated different parts of the electrode and steered the currents in different directions, looking for a part of the brain. When we stimulate it, it fixes this problem. We found a part of the brain, we stimulated that part of the brain, look what happened. So the current, when current was turned on, the behavior, look at the blue graph, and red graph is actually much comparable to healthy people also, but the blue graph got much closer to normal people. So with 100% conflict, 0% conflict, they are almost like normal. With 50% conflict, they are close to normal. So they did much better when we stimulated that particular part of the brain. And not just that, what then we did is we found that part of the brain, what it was. So what we did is we took that patient's brain MRI, we took the electrode positions where it was surgically implanted, And then we did a computational simulation, finding out like where in the brain that current is spreading and which pathway of the brain that current is activating. And it turns out that if you stimulate the dorsal part of the subthalamus and an area called hyperdirect pathway, which connects the motor cortex to the subthalamic nucleus, when you stimulate those two tracks, it actually improves the way you perceive your own motion. This was the work of my postdoc over the last few years, which was published. Then, what next thing we asked is how you perceive your surround. So when you walk, it's not just your movement, it is also the things around you. Let's say if I'm sitting here and something passes by, it is important for me to know when something is passing by. Or when I'm looking at something, I need to look at that thing clearly. I need to know if I want to reach out to that projector, how deep is that projector? I need to know the form of that projector. Is that a two-dimensional object? Is it square? Is it a sphere? And whatnot, right? So what happens is your right eye and your left eye, they are generally straight, but they don't receive the same image. They receive slightly different image. So it's almost like two cameras right next to each other. One is receiving one part of the image, one is receiving slightly different other part of the image. Your brain fuses it and it makes it a 3-dimension. And that gives you a 3D, right? Your iPhone camera with two cameras, it gives you 3D, same concept. So brain has it for ever since we are around. So let's say now I got to the Times Square, right? And now I know how deep that is or how far that signboard is and whatnot, right? Because my eyes are aligned quite well. What happens in some Parkinson patients, even after some people who have stroke or even idiopathic, sometimes their one eye is a little bit crooked more, what we call squint, strabismus. Very common in Parkinson, but very common in general. And when you have that, what happens, your image kind of like get too much moved. And instead of one, you now see two of them. Everything is two, your depth perception is gone, and if it is not too bad of a two, it is blurred, right? So next question that we ask that, can we really find the area of the brain where we stimulate with the electrodes and it fixes the double vision? And again, Parkinson patients have about 70% of them have some amount of misalignment. So that was our window of opportunity to go with an electrode using FDA-approved surgical treatment and find out the areas for the treatment of the next level of the disease, which is your double vision, right? So again, what we did is we have a state-of-art lab in our lab facility where we can measure people's eye positions with a very high resolution of 0.05 degrees and at a temporal resolution of 1 millisecond. So I can measure every millisecond where each eye is with the resolution of 0.05 degrees. So it's very high resolution technique. And we can cover different eyes and measure strabismus very well too. So we put Parkinson patients here, we measure their eye movements, and we ask them to look around and to measure their perception of dimensionality. And as we do that, we wanted to figure out which part of the brain we stimulate, then it can fix this problem. So this is a Parkinson patient. What I'm plotting on y-axis is a vertical eye position and horizontal axis is a horizontal eye position. And what you see that green is your left eye, red is your right eye, and you see that they are both deviated. So Parkinson patients are not able to align their eyes, and what they will see is they will see blurred. Now what happens when I turn on the DBS? They are aligned. Right? So we found particular part of the brain again, navigated through different areas, steered the current in particular part of the brain, it aligned the eyes, and when you align the eyes, your image is clear. So then what we figured out is which area it is where DBS improves strabismus and double vision. And that area happens to be again dorsal subthalamic nucleus. It is very strategic because what happens that there are pathways which connect the subthalamus to the cerebellum, And cerebellum is very important for the perception of your motion and also for movements of the eyes. So when we stimulate cerebellothalamic pathway, that actually modulates the perception of your double vision. And that was the work of my PhD student who is graduating next month. The third question and the last question that I will present today is perception of your surrounds. Now, let's say you got to Times Square, but now you woke up really early and you really want a cup of coffee, okay? And you're looking for a jar of coffee or a slice of bread, for example, right? For breakfast. Now, if anybody, you look at this, we ask our people with normal people and people with Parkinson to find a slice of bread which is sitting on the kitchen counter. What normally people do is they actually go to the area where a slice of bread is supposed to be. So in this case, it would be the toaster oven right there. I don't know where's the pointer, but you see the toaster oven there, right? So a slice of bread should be in the toaster oven. So when you ask the healthy person to look for a slice of bread, the person goes to the toaster oven. What I'm plotting here is a heat map. What tells you is where that person looked at for how long. So the green is for less time, red is for a lot of time, yellow is for a little bit of time. So healthy person looked all over the place, looked at that bowl over there, looked by the toaster oven, looked at the fridge, I don't know why. But then finally found the slice of bread which was below that marker. Slice was not at the toaster oven. Person keeps looking at the toaster oven and they don't even go to where the slice of bread is supposed to be. What that means is as we grow, we learn a lot from our experience, right? You tell me, oh, find the microphone. I'm going to look at the hallway or I'm going to look at the podium. I'm not going to look at the ceiling or some random place in the room, right? Because I learned throughout my life that if somebody asks me for a microphone, this is where a microphone is normally going to be at. Or if I'm looking for bread, where it is supposed to be in the bowl or it is supposed to be in the toaster oven, it cannot be below the marker. So I'm not going to go below the marker. So there is something called priors, which you develop in your brain over your whole life, and you utilize that for your future actions. So your prior cognitive and memory, you implement that for your executive behavior for future, which is lost in Parkinson. What happens? They have a bottom up, which is your retina to the brain, and there is a top down, which is your memory back to your eye muscles or hand muscles, right? Those two pathways, so bottom up and top down, they meet at one place. And that one place has to evaluate who is right. Retina is right or brain is right. Normal people, they go with the brain that, okay, look over there, but then retina says, no, it's not there, it's there. Then it says, yes, retina is right, go there. Parkinson, brain says it's there, retina says it's not there. No, brain is right, just focus on there. So they get lost. See? So that's the problem. What we call hyperactive priors. We think it can even cause the hallucinations in Parkinson patients. They think that, oh, the kids are playing in the backyard. Why? Because their whole life they have seen kids playing in the backyard, but there are no kids in the backyard. But they still hallucinate that kids are playing in the backyard, right? So these priors are again implemented in hallucination. And this is what happens when people have Parkinson. Now what happens when we turn on the DBS? So we did the same patient, but we showed the person a different picture where we asked them to look for the lid of that jar. So you see that little jar, the steel jar? The steel lid is supposed to be on the lid jar, right? We asked them to look for that lid. That lid is actually in the microwave. So that steel lid is not supposed to be in the microwave. Normal person spotted it. Parkinson person with DBS on was spot on. So when you turn on DBS, we found certain parts of the brain, and when we turn it on, they resolve the conflict of where and what. They resolve the top down and bottom up conflict. So their executive behavior also improves. And that happens when we steer the current in a very specific way to the area called ansa lenticularis. I know these are mouthful names, and lenticular fasciculus. In simple word, these are the pathways which are around the subthalamus, not part of it, but they actually go to the parts of the brain where we call where pathway and what pathway. It helps you to kind of navigate through and search the real objects. So with that, I want to just say that future of deep brain stimulation is not just better control of motor systems, but is also to improve our ability to perceive and execute. And it all comes down to location, 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 like Manhattan, right? And we are finding the right one. With that, this is my lab and our research funding. Without that, nothing was possible. Thank you.
I'm sorry, I have more than one question. So, a couple of things. What are your thoughts on the replacement of glutathione in Parkinson's patients? And will a patient with DBS be off the medication after the DBS?
Your first question is what are my thoughts on glutathione in Parkinson?
Right.
So there have been some studies here and there, but it is not considered a standard, something that we do for almost all of our patients. Our staple treatment is, of course, carbidopa, levodopa, and dopamine agonist, and then the neurostimulation. So there is not something that we do for our patients on very regular basis. In fact, I don't have anyone in my practice who's on.
Okay. How
And what
about
was the second question?
medication? Okay, the next one is about the focused ultrasound. I know they don't have much studies done in the US yet.
No, we have.
But I know it's still not in the treatment phase, probably still in the experimental, because I have a patient from Europe. I'm trying to see whether we go for the focused ultrasound or for a DBS.
So focused ultrasound is an ablative procedure. So what focused ultrasound is, what it does is incision-less ablation. So they go in a particular part of the brain, here subthalamic nucleus, for example, or GPI, and they burn that part using the very high intensity sound stimulus, right? Focused ultrasound. The problem with that is that you cannot typically use it bilaterally. It has to be unilateral, because bilateral Parkinson, there are chances in future you will get on the other side. And in that case, if you do the ablation on one side, then what if you get something on the other side? That can be a problem. So I generally prefer DBS for Parkinson as opposed to focus.
Let's give chance to, there's a couple of other folks behind you. And after you, sir, will be the last question. We have to keep it tight.
This is kind of intriguing in a way. Is there any gender difference in the spatial configuration? Because men don't seem to find the things that easily compared to women.
I couldn't hear.
Is there any gender difference?
In Parkinson, no, not that we know of. That is obvious gender difference in Parkinson. It affects both gender equally. And the effects of treatments are also comparable.
Is there any role for like vitamin B1, thiamine? There's some studies from Italy where B1 vitamin seem to help thiamine.
I mean, multivitamin, if our patients ask for multivitamin, we are generally not opposed to it as long as they take it in recommended doses. So most of our patients are on some sort of multivitamin that they get in the grocery store.
So I'll use my privilege as the CME chair of this conference to ask a question. Memory. Memory is also part of, is that part of the same like conflict?
So it's a very interesting question. There are separate studies and separate groups who are focusing on the memory, and there is actually a trial going on with DBS, and they are more focusing on the limbic system. And there have been, I have been to a talk by one of my colleagues, and you go in certain parts of the brain, and if you stimulate it, it gives you the memory of your childhood, just during that period of time. You turn it off, that goes away. So we know that there are parts of the limbic system that you tap in, which sharpens your memory.
All right, and then the other part is, how soon is soon enough to consider DBS? I have some patients who are like early and they're not that disabled yet.
Yeah, so I trained in Atlanta, and my mentor was Malin DeLong, who invented this concept of DBS. Malin always used to tell his patients that when you are ready, we are ready, Delta Airlines. So it all comes down to patients' quality of life. I have had patients who are highly skilled professionals like surgeons or dentists or like, fine workers who have very tiny bit of tremor, and we are very aggressive in treating that fine tremor with DBS for that person, as opposed to I have had patients who are retired and not doing much, and they have bad tremor, but we don't need to do DBS in them. So a lot of it comes down to quality of life when they are ready. In Parkinson, I am relatively more aggressive myself than my other colleagues perhaps, because my concept is, if let's say somebody, we know that they have Parkinson, we know that 5 years later it's going to progress and they will need it, but now they are in much more medically fit position to get the surgery, then we do it sooner than later.
Yeah, no, I had a patient who's with anesthesia, he's a retired anesthesiologist of mine.
So the last
Yeah, so I have a general question. Like when we do deep brain stimulation over a period of time, 3 months, 6 months, a year, do we have some neuroplasticity created where we have lingering benefits even if the DBS turned off? Because we do see similar effects on transcranial magnetic stimulation. We stimulate every day for like 6 weeks or 8 weeks, and then we have lingering neuroplasticity. Right? Does it apply for deep brain stimulation?
Of course, it changes. In fact, it changes a lot when people have tremor or people have dystonia. A lot of time dystonias do not respond to DBS. It takes like 21 days, sometimes up to a year to see the effect. And we think it's not just switching button on and off. It is utilizing the stimulation to modulate the plasticity. And so it works towards helping the symptom also, but on the contrary, for example, in tremor, sometimes the DBS is on and tremor goes away, and then we have to reprogram or we have to keep changing the DBS on regular basis to prevent habituation and some plastic responses.
Thank you, Dr. Sheikh.
Thank you, Dr. Sheikh. For those of you who are interested in watching, there's a beautiful movie called Awakenings. Robert De Niro won the Oscar for that movie about when Cinemet was first introduced, so highly recommended.
And there's another one, there's another movie called I Am Human. It was shot in Cleveland in my hospital. It's a documentary on Prime.
But still as a, Norm, I have to say that he's a neurosurgeon, founder and director of his David S. Zocchi Brain Tumor Center at MMC. He's an attending neurologist, neuro-oncologist. He's got a lot of credentials. So I just can't read them. It's so many. He's a complete person. If you ask me, he's got academic, he's an organization guy, he's an AAPI's vice president this year, right? Secretary. Yeah. So a lot of things. I don't even know how many. And then he's got his chapters and all that. So not much, nothing more. Let me ask Dr. Rawal to come over and take the floor.
Well, good evening, good morning everyone. I hope everybody had a good breakfast. Still people are still enjoying breakfast upstairs. Yesterday we had an entire room full for the CME and people were standing at the end of the hallway. So with the hope of having a cutting edge care, peace of mind and here at home, I started New Jersey First Brain Tumor Center in 2006 when I moved from Stone County to New Jersey. So what is hope? It is one more good day, peace the possible, the first step to success in treating brain tumor. As we know, that brain tumor is unlike any other disease. We take an aggressive team approach to find answers and to prove the hope, to provide the hope. We play to win. We want survivors. Brain tumor is a very difficult disease, as we know. So with that, as a neurologist, I'm also a neurologist, so human brain can only concentrate up to 20 minutes. And if you have a talk more than 20 minutes, you will start doing this, or this, or this, or this. I don't want everybody to fall asleep, so I always keep my talk under 20 minutes. And I have a lot of slides, so some of the slides I may not go through each one of them. So, Central Brain Tumor Registry of the United States has statistics about 14 to 16 cases of 100,000 people, male to female ratio is about the same, and about 40,000 brain tumor patients, primary benign and malignant brain tumor per year. Glioma is about 50%, 80% of gliomas are malignant, and lifetime risk is about 1.3% of all cancers. Again, continue with that 13. Why it is very important? Half of the patients get diagnosed with brain tumor die within the first 12 to 14 months. So it's very aggressive disease, unlike any other medical condition. And male to female ratio is about the same. So this is just a very brief distribution of primary brain tumor by CNS, by the disease diagnosis, tumor site by the site. So brain and the cranial nose, spinal cord occupy about 68-70% of the location. Meninges is about another 22. So large number of patients have benign brain tumor. Meningioma is what we call. Small number has a pituitary, and some other locations that we can see here on picture. So the distribution of primary brain tumor, CNS by histopathology. So this is very important. Every single tumor at this time, what we call personal molecular profile. We do not treat every brain tumor the same way we used to treat before. Every tumor, we look at their molecular, histopathological, and genetic profile and treat them accordingly. So depending on what type of tumor, we will have individual tailored treatment for individual patient. So three gross, we divide tumors in the three different gross types: gliomas, primary central nervous lymphomas, and meningiomas, depending on the location and origin of the cell. Astrocytomas, we call them low-grade anaplastic and glioblastoma. Oligodendrogliomas, similarly low-grade and anaplastic, and epidermomas, also the low-grade anaplastic. Primary central nervous system lymphoma is a very unique brain tumor, which is a non-Hodgkin lymphoma of the brain alone. This lymphoma always starts in the brain and always stays in the brain. Do not pass by anywhere outside the brain. And if it is not treated properly, people can die within 4 months or less. So it's a very, very aggressive brain tumor, and it's very difficult. A lot of time it is missed for a month or two before even people think that this could be a possible tumor type. And then of course many tumors, which are a lot of times incidentally diagnosis, or people will get diagnosed, oh, we have a headache, get an MRI, or by the way, you also have a small tumor. So coming to today's talk, wireless very do cell phone causes a brain tumor. This is ongoing research in my office for the last 20 some years. We are looking at every brain tumor patient and checking to see how long that person, if they are using the cell phone, what kind of right-handed person is it person right-handed or left-handed, how long in a day they are using the cell phone, and all different other parameters that we're looking into. So the background of the cell phone, introduced into the US market in 1984, were not more widely used until mid-1990s, as you can see. Only 14,000 people used mobile phones when they were first invented. Now here is a picture of those phones. By early 2000, the number of the subscribers to the cellular telephone service had grown to estimated 92 million in US, and 2019, 265 million, and in 2030, 285 million. So the substantial increase of the cell phone use. 650 million people in India have mobile phone, and about 300 million have used the smartphone. And why these phone types are also very important, I'll show you in a minute. Different from other electronics, cell phone receive and emit radio frequency signal. So that's why there is a concern arise whether it has a possible health issues, health causes side effect, especially brain. So continue more information. The lower wavelengths are associated with electrical power lines, which is 5,000. Microwaves, radar, and cellular telephones are considered low frequency, low energy devices. Energy of radio frequency waves from cellular telephones are billions of times lower than energy from X-ray. Also, I'll show you more about these things. So lower energy waves are not capable of breaking molecular bonds from non-ionizing radiation. So radio frequency signals are very different from ionizing radiation. You can see here, ionizing radiations are X-rays and gamma rays. These are the only radiation that has the capacity to break break your DNS bonds. All other what we call non-ionizing radiation, microwave ovens, and a lot of times we have information coming in newspaper that if you live near the high wire tension, there is some cause to the health issues, there's so many different things. So these are the basic understanding of what happens if you have using those devices. So why this becomes so big deal? Why there are so many other things can cause medical conditions? Why only our cell phones has become issue? So cell phone has a lot of money involved. Worldwide, there's a huge amount of money involved in cell phone use and cell phone subscribers. And the media, of course. So scientific data, we're looking into these other things and how we're looking to see what's going on with the cell phone. So radiation, of course, it causes immediate radio frequency, magnetic field, heat, what we call SAR, non-thermal, conflicting lab studies, conflicting indirect and direct epidemiological studies. So we look into all different ways to see if there is any truth to this fact, whether a cell phone causing any damage to the brain or brain tumors. So this is the first thing that happened when this came initially. Larry King Live. Can you take this video on the right?
David Bernard runs an answering service for doctors. When his wife Susan became pregnant, he gave her a cellular telephone to make life easier. She used it 2 years, up to 150 minutes a month, according to her husband. During that time, Susan Bernard developed a brain tumor and died last year. Her husband has sued the distributor of the phone, NEC America, as well as the companies that sold it and provided the service. He claims microwaves from the phone caused or promoted his wife's fatal brain cancer. Bernard says magnetic resonance images, MRI, taken of her head during treatment bolster his case.
These MRIs showed this tumor to be at almost a precise location of the middle of the antenna. And the tumor grew inward from that location, from the outside of the brain into the brain.
NEC calls the lawsuit entirely without merit, but no one from the company would appear on camera. A spokesman said there is no medical evidence linking the medical condition to the cellular phone. Some industry experts aren't so quick to dismiss a possible connection.
That antenna is right next to your brain, right next to your eyes. So, if that radiation can travel so far, can it do damage to your brain? It's certainly possible.
There's little research into whether cellular phones can be harmful to health, and none of it is conclusive.
So this was the Larry King Live, and this raised concern all over the world, of course in the US, and everybody started to ask this question to
We now welcome to begin things on this major discussion on cell phones, Dr. Chris Newman. He's at our studios in New York. He has brain cancer and is suing a cell phone maker and a telecommunications company, claiming they caused the cancer. Joanne Suter, his attorney, is also with him. We'll spend the opening portions of the program with them, and then a major panel discussion on all this. Dr. Newman, how do you know they caused it?
I believe they caused it. I'd like to defer on that question to my attorney.
Joanne, how do you know that Dr. Newman's use of the cell phone caused the cancer?
Larry, in this case, there really is no question about it. That after Dr. Newman was diagnosed and began treatment, his own physicians made the correlation between his longtime cell phone use and his cancer. He also has documented, unfortunately, 9 years of a vast amount of cell phone use. And his terminal tumor is located in the exact anatomical location where the radiation from the cell phone emitted into his skull. So in this case, it's really not a question at all.
Okay, so that kind of raised all the different marketing gimmicks, and people started to see this kind of advertisement on the TV. Everywhere people were abusing what I call emotional blackmailing, but people were selling this kind of devices, and if you buy this small thing on a cell phone, just stick it on the phone, you will prevent those brain tumor happening. And people started making money out of this another device. All this kind of thing started with marketing gimmicks, where people started to get information because of those two videos letting live, thing and concerned people. So then we started looking to see what's going on. We started all different kind of approach. So phone critics to see what's going on. So the only one known cause of brain tumor is radiation. So in the many years ago, in the past, teenage diabetes used to get low as a treatment, low dose radiation as a treatment for those teenage diabetes. And a primary brain tumor, we used to give them high dose of the radiation. Those people can develop secondary low-grade brain tumor, or they develop melanomas and they get some sort of treatment and get whatever exposure to the radiation, the only known cause of brain tumor. That's the only thing that we know at present time, the cause of the brain tumor. Ionizing radiation is the only type of radiation that can cause brain tumor. I'll show you in a minute. Cell phone, as you can see here, ionizing radiation amount of frequency and cell phone frequency. So this is a kind of very basic understanding of all the different kinds of radiation that we need from different things. My computer is working. So all these power lines and all different things that we know that we are concerned about radiation causing damage are considered non-ionizing radiation. Those non-ionizing radiation does not cause any damage, does not cause any health injury. Only known cause of health injuries are the X-ray and gamma radiation, or the radiation sometimes radiation treatment, even the radiation from CAT scan. CT scan, we think that everybody gets CT scan like peanuts nowadays. Now, you see get a CAT scan in emergency room. 2% of cancer in the United States are caused by the radiation just from testing from the radiation. So this is the first talk when I gave this many years ago. My kids are now, so the last picture, but these are that they were so young. Passing out a questionnaire for you to complete, so you can be included in the raffle tonight. But the winner will get an Apple iPad. Please make sure to complete this questionnaire so you can be included in the raffle. And with that, please welcome Ed Scott, partner of Wall Street Alliance Group and my good friend.
Thank you, Dr. for the kind introduction. Hello everyone, my name is Sayed Dishad. I'm on the partner at Wall Street Alliance Group. We're going to have just an interactive day. We're going to pass this questionnaire, and for people who pass this questionnaire, we're going to have a raffle and they're going to have to get a free Apple iPad. So please complete this questionnaire as soon as possible so we can announce the winner before the break. Mic is not good? Is it better now? Okay. Now, estate planning is very important for physicians. Now, can I get a raise of hand? How many people have a basic will set up? Basic will? Now, just to give you an idea, if you don't have a will, as simple as the custody of the children will be decided by the US government. And your children will not have access to the assets for a long period of time because it goes through a probate process. Everyone, please listen up at the back. Now, a lot of people ask the question, when should I create like a trust? And what is the difference between a revocable and irrevocable trust? How many people have a basic trust set up? Little brother, how many people have a basic trust set up? Some of you? Now, just to give you, all right, everyone please listen up at the back. Now, just to give an idea, what is the difference between a revocable and irrevocable trust? A lot of people ask the question because I have less than 6 minutes right now. The revocable trust is mainly to avoid probate. Again, mainly to avoid probate. And another second advantage of a revocable trust, after you pass away, it becomes irrevocable by law. Your children inherit the money. If they get into a divorce or lawsuit, all the assets are protected. That's the benefit of a revocable trust. The last benefit of a revocable trust is a step up in cost basis. How many people have NVIDIA, those stocks? Some of you? Now, if you have NVIDIA stock and you let's say bought it for $100 and stock right now is $200, if you pass away, if you give the money to a revocable trust, the children's cost basis is $200. They get a step up in cost basis, is tax free. So again, appreciated property should be under a revocable trust. Irrevocable trust, a lot of people ask the question. This is mainly for gifting purpose. Right now, husband, wife both pass away, up to 26 million, there is no estate taxes due. Everyone knows that, I'm assuming. It is expiring next year. Husband, wife both passed away. Anything more than 13 million from next year, we're talking about 50% almost estate tax. How many people over here from New York? New York? New York, you guys have something called New York state tax, which is more than $7 million, progressive 15% state tax. How many people over here from New Jersey? New Jersey, you guys have inheritance tax on top of the federal tax. So again, one of the problems you guys have is that we have federal tax which is expiring next year, and you guys have an inheritance and state tax as well. Now, what's the best way of gifting money? You guys can take a picture because I have a very short time, but I'm going to go through very quickly. How many people have children here? Okay, all of you, $80,000 per child, you can gift money. As many chances you have it, 18. Husband, wife, $36,000 per child every year. How many people have grandchildren here? Alright, grandchildren, what happened, make sure they go to private school. Because what happened, if you pay for their private school, if you pay for their medical school, or if you pay for their medical expenses, this is on top of $18,000. Understand? Pay the money from your state. So that money is out of your state. Number 3, irrevocable trust. Irrevocable trust, you can gift almost $26 million before the law changed. Because what happened, if you don't do anything, and if the law changed, you cannot give too much money from next year. But let's say if you give $13 million right now.
Can I please not talk loudly? We have a sponsor who is trying to give information. Can you please keep your voice loud so people can hear who is here, who wants to hear, please?
Okay, thank you. So as I was saying, that if you don't do anything, and if the law change, you don't have an option to give too much money from next year, before the law change. And if you gift it, it is grandfathered. That means if the law change, it doesn't matter. So how much can you gift? Almost $26 million you can gift this year, and this money is out of your state. It goes state tax free. It is expiring next year. Now, how many people are charity minded? Some of you give money to charities. Now, a lot of people say, my net worth is 40 million, 50 million, what do I do? Alright, for those individuals, charitable lead trust right now is very important. Charitable lead trust. What happened, anything up to 26 million is part of your state. Anything more than 26 million after you pass away, the beneficiary could be the charity. The way the charitable lead trust work, every year 5% you have to give it to the charity. After 20 years, whatever is left over goes back to your heirs. Everyone knows you buy SPY for 20 years, the return is easily 8 to 9%. So what happened? 5% you can easily give it to the charity, whatever left over goes back to heirs, all estate tax free. Again, if your net worth is 40 million, 50 million, think about charitable lead trust is very important. Another thing you can do is buy second to die life insurance policy. Usually the ratio is 1 to 9. That means if you buy for $1 million, if you put cash, you get $9 million life insurance if you're in good health. So you can think about buying second to die life insurance policy, and the death benefit can pay for it. And lastly, everyone, I know that our Indian community, they pay off their house and they buy the most expensive house. If you have an expensive house, especially in New York, New Jersey, it's not uncommon. There's something called QPRT. It's only for personal residence trust. You can put the money into the QPRT and you can design in such a way that after 5 years, 10 years, you can pay a rent and the residential property is out of your state. Again, all of this stuff are there. People ask the question, how much does it cost? A revocable trust costs about $3,500 to $4,000. Irrevocable trust, again, $3,500 to $4,000. How much does charitable lead trust cost? About $5,000, and that's it. So ladies and gentlemen, I have only 8 minutes, but only in less than 8 minutes, there's only so much I can talk, but like it or not, estate planning is the foundation to give our family stability. So we have a booth outside, we have another talk tomorrow and tonight. So if you're interested, make sure that you fill out this questionnaire, you pass on the table. If you have 1 or 2 questions, I can answer, but I think we're running out of time. So thank you very much, the audience, for the time. I really appreciate it.
whatever excess money in the irrevocable trust. Now, is there any tax in the future?
Yeah, so the question is, whatever money you put in right now, excess money, is there any tax in the future? No. If you, let's say your net worth is 10 million, I'm just giving an example, and you put 5 million into the irrevocable trust, this 5 million is out of your state, and it goes to state tax free. Again, extremely powerful, but the good candidates' net worth should be about 15 million to start getting it, because the law will change, it will come down to 13 million if it happens.
If you have CDs or liquid for about 1 million, for example, and you put TOD to your children, and you don't have trust, does it go through probate or not?
No, if you put TOD designation, there is no probate. Understand? If you put designation, there is no probate. The benefit of the revocable trust is to avoid divorce protection for the children. That's it. There is no avoid probate. Any question?
So if you already have the trust, if you want to put the $5 million in, what is the documentation requirement to say that this belongs to the trust and not belong to my?
Yeah, so basically you have to file something called CRAMI letter, every year, and gift tax filing. It is called a CRAMI letter and a gift tax filing. It is called 709. You have to complete it. And that's basically a good faith. It goes to the government. It just says it belongs to the irrevocable trust. That's it.
Evaluated concussion is C-spine and cervicogenic dysfunction. So what is that, right? Most of the time you'll see patients always complaining of neck stiffness, neck pain, decreased range of motion, occipital type headaches. And then why do we see this is because we have a densely innervated C-spine with proprioceptive and mechanoreceptive fibers with different levels to the CS. So that could be the pain generator for their headaches and balance issues a lot of time. All right, so this is just an example of a physical exam for cervicogenic dysfunction for concussion. We always want to make sure that their range of motion is intact, and then if we have any pain generators at the C1, C2 facet joint, we can say that this may delay recovery and have persistent concussion symptoms. The other thing that people call concussion, usually you'll see someone diagnosed as concussion. When was your injury? 10 years ago or 6 years ago. I mean, that's no longer a concussion, right? You should be better between 3 to 6 months to cause a concussion. Within a year, I'll still call it persistent post-concussive symptoms, but after that, it's a traumatic brain injury. All right, so there is a test that we use. It's exertion testing. It came out of the University of Buffalo called the Buffalo Concussion Treadmill Test. We want to have patients get on this before they start treatment, during and after, to rehabilitate them to getting their visual and vestibular system aligned. And if they can pass this exertion test with no issues, then they're ready to go back to play, let's say. So most of the time, we'll have them come up to a targeted heart rate and then exert them for about 10 minutes and 5 minutes to 10 minutes, and if they have no more symptoms, then I'm ready to clear them back to activity. So this is a lot of autonomic dysfunction, okay? You have to be aware that a head hit to the brain can have far-reaching effects, right? Headaches and dizziness is most common, but the autonomic nervous system, they can also come with a POTS-like diagnosis. You should test their orthostatic vital signs, get a good ophthalmologic oculomotor exam, test their neck. Postural and motor control is very important. And this is where good vestibular physical therapy and ocular PT come in as well. I think a lot of this is very technical, so I'm skipping it. This is basically what I had just discussed. We know what positive orthostatics are. Drop by at least 20 millimeters of mercury or diastolic by 10 when they stand up. And a lot of times we can treat them with increased sodium or compression socks, or usually they will have to get on low dose fluorocortisone or something that will retain water or salt. All right. A lot of times they also have baroreceptor dysfunction, so we all know that about this in cardiology. You need to have a good cardiologist as part of your team to be able to see these patients, assess them, and then treat them. All right, and this is the most common, and this is why anyone in migraine management will see a lot of these patients that as neurologists. The persistent post-traumatic headache. It's defined as duration of more than 3 months of the traumatic injury to the head. And this is just AHS criteria for persistent post-traumatic headache. And then a lot of times they don't even have to lose consciousness, but they should regain it within 30 seconds to a minute, okay? And then a lot of times people are very confused. How do I treat this? What do I do? A lot of times in the beginning, what I do is try to maximize their lifestyle, make sure they're sleeping on time, exercising, water intake is very important, but then after that, we have to move to the abortive and preventive medications that are already being used by headache specialists, in addition to rehabbing their neck and doing nerve blocks as necessary. So Botox is probably the last thing that we do. Now we have a lot of CGRP injectable medications, but that would be after you try and fail 3 oral medications. So there is this is the oldest medication, right? Amitriptyline, lots of side effects, but these, some of the recent studies show that there was really no effect. But actually I disagree, because I tend to use nortriptyline a lot, especially in my younger patients, and they have good benefit from it. A lot of times you see decreased mood, this will treat the mood, it'll treat the sleep, if there's sleep disruption. You want to overlap one medication with as many symptoms as possible, so you don't have to put them on multiple things. I'm a big believer of supplements as well, but this is outside the scope of this talk today. So things like magnesium, CoQ10, those things actually really help. So we can also use metoclopramide. We know that's Reglan, because that's going to hydrate for acute post-traumatic headache, especially if they have nausea symptoms. And the newest things on the market are this calcitonin gene-related peptide, the CGRP. They have oral as well as injectable medications that can help reduce their headaches up to 75%. And then everyone's familiar with Botox. You know, they are done in the same site as for regular migraines. And then there's neuromodulation. For someone who really just does not get better, there's TMS, transcranial magnetic stimulation, which I'm not a big believer of, because after people have gotten TMS, I end up seeing them and they have worse symptoms. I think it may be better for non-brain injured patients with just depression, but you should proceed with caution if they have any existing brain injuries and they're going for TMS, okay? And then they have direct transcranial stimulation. They have a lot of like these devices that you can put on your head. It's sort of like a small TENS unit that seems to help interrupt the pain cycle. All right, this is just an interruption in the talk. So this is someone from the University of Florida. He used to be the football linebacker, and he's now an alumni, so I got a photo with him backstage at one of the games. So other things you really do have to screen for is psychiatric disorders and MTBI. That's very, very prevalent. You do have to ask about mood. Depression and anxiety are significant predictors, both of persistence and severity of symptoms. And a lot of times, I mean, especially if we work in these big cities, right, everybody is anxious. They just do a good job controlling it prior to a head injury because of exercise and trying to sleep on time and taking supplements. But once they have a head injury, they can no longer control their anxiety or depression. So we really do have to screen them and get them on the proper medications and treatment and talk therapy at that time. Also, I've seen post-traumatic Parkinson's. I've seen post-traumatic bipolar disorder. I've seen post-traumatic other psych disorders like cyclothymia. So it pushes the person and lowers their baseline for these symptoms. So you'll see personality changes, apathy, affective disorder, headaches, and hypervigilance in these patients. They can have PTSD depending on what the method was because of their injury, right? They won't want to drive anymore if they crash into a tractor trailer. So you have to then employ psychology, kind of sensitivity, training to expose them to the stimuli to get them back into normal functioning. And then, we also do cognitive behavioral therapy. Everybody's heard of this, especially in veterans. It really did help after any type of injury. And then we talked about psychiatric disorders. Usually the scales we use for the same for depression, the PHQ-9 and GAD-7. And so this is actually a really pretty diagram of all the symptoms and signs you may see and the teams that might treat them. This was from a publication I had in the British Medical Journal of Sports. So if you look at the top leaf of the flower, that's the vestibular dysfunction. On the right is cognitive. And we have fatigue, which is the most non-specific thing. And forget it, when I had COVID-19 patients then hit their head, it was something that I had to be very creative and figure out treatment protocols for them. Then anxiety, mood, headache, migraine, and oculovestibular dysfunction. Okay, so then you basically have to see that a lot of these overlaps, they don't exist in a vacuum. These are the brain regions most vulnerable to traumatic brain injury and why they would change someone's behavior, right? We know the frontal cortex has all of our students. It's like a neuropsychological test that's administered by a computer, but it doesn't have a high reliability. It has high sensitivity, but reliability is poor. But in the long run, it's better for screening than not. I would not base all my decisions to return someone back on a plane because of this test alone. All right, so we talked a little bit about this, about when do we send someone for neuropsychological testing, right? There are a lot of past history. If they have a history of traumatic brain injury before, this is the second or third time, or they have depression, anxiety, some other brain issue, genetic factors, any cognitive function. So usually in my screening, I'll ask them, did you have a diagnosis of ADD, ADHD before, or have you had, a learning disability? Do you have anxiety, depression? Do you have a history of migraines and neck pain? So any pain generator is just going to be 10 times worse after a head injury. And this is a visual vestibular oculomotor screening called BOMS. It tests your eye movement, and we say that the eye is the window to the soul, right? So the movement of the eye being slower than baseline is going to give us information that they have been concussed, as well as the need for oculomotor therapy. And this is basically how you do it. You test convergence, the horizontal and vertical VOR, visual motion sensitivity, horizontal and vertical smooth pursuits, and then vertical saccades. And if they are getting symptomatic while you're testing this, instantly they're going to qualify for further readout. All right, so there are more tests. This one is out of NYU that kind of tests your, speed of naming numbers as well as pictures. So this is actually free on Android. It's called the Mules, the MIC test, and it's very easy to get for free to assess your patients. Especially during COVID, this was relevant. We switched a lot to telemedicine to service our patients. I still can see these patients, especially between campuses, because I can still do ocular testing while I'm seeing them on telemedicine. This is a balance test that we use for vestibular ocular dysfunction. Just to make it very simple, they stand on a firm surface and then a foam surface with eyes closed, eyes open. And then if they have a dysfunction within a couple of seconds, then you know that the balance is off. This is another one of the tests that was one of the newer tests came to test for concussion management. All right, so summary and recommendations. Concussion evaluation is basically a dynamic process. So you have to have colleagues from physical therapy, obviously sports medicine, neurology, right? So even a lot of neurologists don't know how to treat concussions, so they're extremely happy that I have this fellowship, and then your wait list grows and grows because it's just very difficult to assess them. They have so much going on. Routine neuroimaging and neurology exam is limited in yield a lot of times, and cervicogenic dysfunction is often underestimated. Psychiatric comorbidity must be addressed, and you need to do neuropsych battery testing, and vestibular ocular parameters should be considered in ongoing evaluation of a concussion patient. Right, I think that's probably my last slide, so it doesn't matter that it's not working. All right, thank you for your attention. Absolutely, I agree with all your sentiments. In terms of getting coaches and athletic trainers and everybody on the same page, unfortunately it's at a state level. So New York, New Jersey, they all have different rules for middle school, high school, and how they're actually going to baseline. NCAA, NFL, they all baseline. So I was part of the baseline testing, and for those who are listening may not be familiar with it, we test them when they're normal, and then we retest them after injury to see what the difference is, and then we have basically the difference to see whether or not we have to pull them out and how long they need treatment. And the other thing is, there is a push towards the coaches and the athletic trainers, and biggest problem is funding, right? So money talks, the problem is funding, and just educating them about how to actually test these students and get them back to baseline. Yeah.
$2 a student for
right.
is $2.
And awareness, that's the other thing.
The parents are willing to pay.
Right.
It's a question of making it awareness.
Yeah, so that's where a lot of these national brain injury and AAN kind of comes in, and I'm always happy to talk to whoever via Zoom if any of you want me to, speak at your institutions, because I think that awareness is very important. Thanks for your question.
Hi, Dr. Datta. Very nice talk. Some of the abbreviations were not clear to me. I'm in geriatrics, so a different opposite spectrum compared to that patient. We have patients falls, and I'll paint the scenario. If a patient on Eliquis had a fall and then was sent to ER, they did a patient CT scan and sent the patient back. Now I am evaluating the patient has early dementia. How would you approach this? This is a typical scenario that I come across every day, every week.
Right, so the biggest thing is, why did they fall? That's the question we want to answer. Is it a mechanical fall? Did they trip and fall on a rug? Or were they vertiginous? Were they dizzy? Or is it because of their heart? Or is it because of their brain? So you definitely want to do vascular studies like MRA, sometimes MRV, depending on how they present.
They don't even approve it. Even if we try to get those ordered, they would not approve. The insurance would not approve.
Well, you have to put in the correct diagnosis codes like concussion, vertigo.
Yeah, patient gets a bump on the head, and even then there is difficulty getting. So you haven't come across that?
I actually have not. Maybe it's because then by the time you send them to a specialist, they end up approving it. But I do come across a lot of times where there's orders stuck in the system. When they see me, I say, oh, this was ordered by your GP, how come you haven't done it? And they'll say, oh, it wasn't approved. But when I put it in, it gets approved. I don't know. It's just a real problem.
What is your go-to code in that? What code would you use?
So I usually use traumatic fall or concussion or vertigo.
Okay.
R42, vertigo.
Every company, every insurance company has different ways to get things done. But we'll take this last question. Okay. We're running short of time.
Okay, sure. Excellent talk, Shay. My question is, do you use any AI or any other algorithms to screen as many patients as possible?
Yeah, that's a very good question. We're moving into the realm of AI more for prognostication and further seeing what patient population and how long that they're going to take. Right now, there's not so much AI in actually diagnosing them because you need still that human interaction for us to say that, oh, they look a certain way and they are saying one thing and then the physical exam is this way, and then you just get a feeling, right? All of you, when you see your patient back, you have this feeling like what is going on. A lot of times people ask me to explain, I'm like, I don't know, I just look at their face and I know what I have to do. It's very difficult to always put in treatment protocols for every single thing. But we are using AI to prognosticate, the most common question you're going to get, doc, how long is it going to take for me to get better? And I'm like, I don't have a crystal ball. I wish I did. But based on the fact that you're young, you haven't had any head hits, if you fixed your sleep and we get you to rehab, you should be better. Someone with dementia, multiple falls, multiple spinal issues, that's going to be more of a challenge, right? Then I say, okay, let's say 6 months, but then you may actually have some of these symptoms long term.
Thank you, very excellent presentation. I've been on the both sides. I've been a college football physician and also taking care of people after the concussion. You give a lot of insight, but bottom line comes, there's no treatment. All these things you told, the psych or this or that, these are the general medicine problem. Whether they caused by the concussion or episodic. We still have to treat them. So there's no really cure. So I don't know, you can diagnose concussion and then you don't have to really say, okay, there's not much you can do about it. You just live with it. So that's I wish there was more research where you said, okay, here's a concussion, let's reverse it. All the neurological damage has done. But we're not that stage. So it's an excellent presentation of pathophysiology, but in terms of helping the patients, it's not there. And the college football people, when they call you on the field after everything had piled up and guy's concussion, their main thing is, doctor, can he go back on the field? That's all. When he had a concussion, and then they put you on the spot and say, oh my gosh, what? Well, he's our best player and he needs to go back on.
Thank you for your input, and
Yeah, I think things have evolved a lot, so there's a lot of specialty trained doctors like me coming out now. I guess I'm one of only 35 or 40 people with this fellowship. And even sports medicine doctors don't know how to really treat concussion. They'll send them for regular therapy. So yes, it's a lack of awareness. Perhaps, even at AAPI or they should have like specialists come and see at least how to prognosticate them and send them to the proper places. So I agree there's a lot of like confusion in this field, but there's definitely treatment. I have gotten people, I have about a 90% success rate of getting people back to pretty much 95% of their functioning after they have a head injury. So.
Thank you, Dr.
Yeah.
Excellent. We will rush through these. Do you want to give, we have a give prize for the raffle that we have. So, and the winner is Vivek C. Vai. Oh, here you go. Excellent. You get a, come on, you get your, the next talk is the internist challenges by our own Indrapal Chabra. Is this? Can you get the talk up, please? And he is the CME convention CME chair, and so he has a lot of insight. His current position is the Chief Medical Officer of Cirrus Health Services, his own health service with a lot of employees under him, and I'm happy to welcome him for the talk.
So we have been getting some wonderful talks by wonderful people who are bringing you the latest and the greatest. I want to take you back to some basics. And I just want to understand the audience here. How many here are primary care physicians? Oh, fantastic. So then I'm talking to my own tribe here. And I picked up 3 topics that I see almost every single day. And the fourth one was diabetes. I had to leave it alone, otherwise this talk would have gone on forever. So basically, I'm going to talk about, most of my talk is going to be about hypertension. And I'm not going to give you the latest and the greatest on how to treat hypertension and how you're going to do. Tomorrow, a friend of mine is going to be talking about renal denervation for hypertension. Just make sure you listen to that. And then I'm going to talk about something very basic, upper respiratory tract infections. I mean, if you're internists, you're primary care doctors, you know that in the next few weeks, you're going to start seeing a lot more people with these sniffling and headaches, and everybody's going to come in and ask for a Z-Pack. So is that the right thing to do? So that's what I'm going to talk about. And then the second most common thing that we see in the office is back pain. And it's like, from a primary care perspective, an MRI is not a treatment for back pain. Everybody comes and asks for an MRI. MRI is not a treatment for back pain. It does not, last I heard, it doesn't treat anything. Alrighty, so this is based on 2017 guidelines. Last I looked, these guidelines have not really been updated. There's a whole alphabet soup of different organizations that have endorsed these guidelines. So what is definition? Let's start by defining hypertension. So if you look, anything above 129 systolic or 80 diastolic is considered hypertension. Now if you're 20 points over, then you belong to stage 2 hypertension. Otherwise, if 130 to 139 and diastolic of 80 to 89 is basic stage 1 hypertension. Alrighty. About 2 years ago, the NIH folks came to Long Island and they did like the population health survey kind of thing. I volunteered, me and my wife, we volunteered for that. And we were taken to their van and somebody from the NIH checked my blood pressure. Guess how that blood pressure was checked? They asked me to come in, sit down. As soon as I sat down, a timer was started. After 5 minutes, I was asked to put my arm, and the person who was checking my blood pressure adjusted the height of where my arm was resting to bring it to my heart level. Once I stabilized, that's when blood pressure was checked. That is the most accurate way to check the blood pressure. How many of you have this in your office? Can you do that? Okay. Put the arm at the level of the heart, individualized to each patient. Okay, great. I'm glad that some of you do that. You have to have a minimum of 3 readings and average those readings. A lot of times I would walk in and the MA would have checked the blood pressure. The blood pressure would be 155 over 90. And when I checked the blood pressure would be 127 over 80. So an accurate reading of blood pressure is very important. And then there's it's not really a new concept anymore. When it came out in 2017 after the JNC things, outside of the office, how's the blood pressure doing? There's a big role of remote patient monitoring and ambulatory blood pressure monitoring at home. I had a banker for a patient who would email me his blood pressure readings. He was one of the first ones. Back in 2012 or 2013, he used to send me his blood pressure readings from home. He had a Wi-Fi enabled blood pressure device. His iPhone would get the blood pressure readings and he would email it to me just to prove, Doc, I don't need a pill. His motivation was he did not want to get on a medication. Alrighty, so this is a slightly busy slide, just concentrated on the top box. We're talking about when do you suspect secondary hypertension? If it is drug resistant, anybody with a new onset of hypertension, you should start thinking, what's the secondary cause? And then broadly, we can divide it into 2 or 3 different categories. Is it coming because of something happening in the kidneys? Is it a renal parenchymal disease? Is it a renovascular hypertension? Then let's start thinking about the endocrinopathies. Let's talk about their target organ damage. And is it accelerated? Suddenly somebody's blood pressure has been okay, like 130, 140 systolic, and suddenly they come in with a blood pressure of 189 systolic. What's happening there? Did they have a Chinese food the night before? Or was it something else happening that could potentially cause a stroke? So unprovoked or excessive hypokalemia, that's also an important thing. When you check the labs, make sure the potassium, you're looking at the potassium. That could be a clue. And then, if you have a positive screening test for that secondary hypertension, make sure you refer to the right specialist. Is it a nephrologist? Is it an endocrinologist? Or is somebody else that the patient needs to see? So again, the common causes are common, right? So that's one of the basic things. Uncommon causes, somebody's blood pressure is 190 systolic, don't start looking for a pheochromocytoma first. Start looking for the common causes first. And then again, it's surprising, both hypo and hyper, both of them can cause uncontrolled hypertension. Alrighty, now we start with non-pharmacological therapies. What do we start first? Weight loss, number one. Try to get them to lose some weight. It is sort of easier now with the GLPs around, and I'm not going to talk about the challenges of getting them approved from the insurance plans, but that's a different discussion. I used to be a medical director of an insurance plan also, so I know how they think. DASH diet. My EMR, I always, anytime somebody comes with a new onset of hypertension, my click goes to patient education and I print out a DASH diet. And I make sure that the patient understands what a DASH diet is. Sodium reduction, potassium supplementation, all of those things are very basic. Another basic thing is increased physical activity. Even yesterday Dr. Oz was talking about just 10 minutes of increased activity can improve your blood pressure. And now the last box, how many here enjoy the liquid libation? There's a little bit of ETOH at the end of the day. I mean, I do. Don't be shy. It's part of life, right? Okay. Now, what is the definition of a standard drink? Can you guess?
5 ounce wine, 12 ounce beer, 1.5 ounce spirit.
What is 1.5 ounce? In Punjabi, we say, yeah, that's not the movie nikilla That is the definition of one standard drink. And Patiala pack is about 10 times, maybe more. So no more than 2 drinks for a male and 1 drink for a female of a 1.5 ounce hard liquor. That's the definition of a standard drink. That's the limit. All right. Now, initial medications, like I said, I'm not going to talk about the differences in the medications. Thiazide diuretics, we have all the choices, CCBs, ARBs, ACE inhibitors, beta blockers. Actually, I misspoke. Beta blockers are not in this list. I see a lot of old, I took over some practices a couple of years back, and some of the patients who have been seeing the older physicians, they're all on metoprolol, atenolol. All of those are out the window. Beta blockers are not the first line of treatment anymore. Unless you have a reason. I'm going to talk about that. Alrighty, monotherapy versus combination therapy. If the blood pressure is more than 20 points systolic or 10 points diastolic above the recommended blood pressure of less than 130/80, think about starting off with 2 medications from 2 different categories. We have wonderful combination drugs of ACE inhibitors plus thiazide diuretics, calcium channel blockers, and then you can add a thiazide. In my practice, I get a lot of patients who coming from India, and you get all kinds of crazy combinations from India. One pill, we have 5 different things. That's sometimes maybe an overkill, but think about a combination drug if you have more than 20 points above systolic. If it is less than 20 points, maybe you can get away with 1 pill, with 1 class of drugs. Alrighty, now you've started somebody on hypertension medications. How often will you see that patient? Dr. Lavakar, when do you call the patient back? Once you've started some treatment, when would you start the patient back? Every 3 months. Dr. Rakesh, 1 month. Alright, that's yeah. Right. So that's if you're on a thiazide diuretic. So I heard response between 3 months to 1 month. The recommendation from these guidelines is at least within a month, 1 month. That's the recommendation from the guidelines.
You can check creatinine if you start an ACE.
Again, once you're checking the patient back in 1 month, sometimes it's very difficult to get the patients back that soon, depending on their copay, or I've been seeing patients with copays of $40 for the primary care visit. Alrighty, now, stable ischemic heart disease. I'm not going to bore you, I am going to give you the definition of those acronyms that I'm using. Stable ischemic heart disease. That's when you have a role for beta blockers. Do not use atenolol. Atenolol has an intrinsic sympathomimetic effect which can make angina worse. Do not use atenolol. Metoprolol, lucidolol, nebivolol, there's so many other wonderful beta blockers out there that are available. And then again, if you see angina, any signs of angina pectoris, calcium channel blockers, dihydropyridine calcium channel blockers, amlodipine, nifedipine, those are the drugs that are still out there. Alrighty. Anybody with CKD, you gotta look for proteinuria, albuminuria. If you're seeing that, make sure you use an ACE inhibitor or an ARB. Alrighty. And if they're, of course, the flows from there. I'll talk to smart people, I don't need to elaborate more. Okay. Now, somebody with diabetes, again, they have the risk for proteinuria, so we got to introduce ACE inhibitors and ARBs much earlier. But any control of blood pressure will control albuminuria, so don't just be increasing the doses of ACE inhibitors and ARBs all the time. Think about calcium. The control of blood pressure is more important. All right, rates and ethnicity. The guidelines talk about African American patients, but I have seen in my own patients with the people of Indian descent, I do have to add thiazide or a calcium channel blocker much earlier. And treatment of hypertension in older persons. There was somebody here who was a geriatrician, and my wife is attending at a nursing home, and we see blood pressures, people with high blood pressure all the time. You've got to be careful about falls. If you're giving a thiazide diuretic and you're making them fall, well, from orthostatic hypertension, you've got to think about that in older physicians, in older patients. Alrighty, so this is a summary. Again, I'm not going to speak to the slide. This is kind of self-explanatory. Get an accurate blood pressure before you decide, before you put somebody on lifelong treatment. That's the most important part. And make sure you do check the blood pressure outside of the office also. There's a big role from RPM and other modalities. Alright. Okay, switching gears. Upper respiratory tract infections. So I went around looking for evidence on when do you treat and what do you treat upper respiratory tract infections with. Does anybody who walks into a CME around the corner or any urgent care around the corner from your office, they walk in with a sniffling or a cough and cold, they get a Z-pack. Is that the right thing to do? Evidence is a big no. If you send up the Dr. Kakani with an ENT surgeon in the back, he's going to make sure the patient actually does need an antibiotic before they get an antibiotic. Alright, we're going to take a look at some of the evidence. Alright, so this is the abstract. This is the Archives of Internal Medicine. That's what I pulled the data from. Alright, unless you're suspecting pneumonia and the patient is having symptoms of bronchitis, you don't need to think about antibiotics. Think about antibiotics, not prescribe antibiotics. If you're suspecting group A streptococcal pharyngitis, make sure you do a test for that. It's a simple strip. Just test for group A streptococcal with a steroids with a strip. These are central criteria. I pulled them up from up to date. 4 points for each, like 1 point for each of these. If you have more than 3, only then prescribe any antibiotics. And look at the last one, absence of cough. Absence of cough. Everybody who comes in coughing, they may not need an antibiotic. All right, so the IDSA guidelines recommending only with a positive streptococcal test, that's when you need antibiotics. Rhinosinusitis, again, a lot of our ENT colleagues, they get referred to for these things. If the patient's symptoms are persisting for more than 10 days, then you might need an antibiotic. 10 days, not before. And again, the rest of the symptoms are, you all know these symptoms already. Headaches, or maxillary headaches persisting for more than 3 days. And then there's, it's kind of at the bottom, there's something known as double dipping. The patients had symptoms, they were improving, and suddenly they get worse within 5 days. That's called double dipping. That could be a sign of a secondary infection, so that's when you might need an antibiotic. Alright. I don't need to say it. Don't give antibiotics. Alright, so the symptoms can go up to 2 weeks before they get better. This is a busy slide. You can look it up on the article that I sent out, that I referenced earlier. Okay.
This is awesome. What can you do with it? Well, you can put data in, patient data. Soon, what would happen with healthcare in particular is the computer started to become a place where you can store data, you can process data, and one of the first applications was medical billing. But regardless, there was this one man, and I look him up, his name was Dr. Lawrence Tribe. He was the first evangelist for the fact that computers can become a single source of truth as far as health data is concerned. What has happened now? Well, a single source of truth is absolutely elusive as far as healthcare is concerned. It's still interesting to think that 1960 is where healthcare started to look into a computer, a time when no one knew what to do with a computer. And what eventually started to happen was we started to put these computers together. I'm going to throw this challenge out, and this is every bit true, no matter who the audience is. The only reason you own a computer is because there's this thing called the internet. The only reason you own an iPhone is because there's this thing called the internet. If you don't believe me, pull out your iPhone, put it on airplane mode, you don't need it anymore. You don't even want to touch it anymore. Same thing happens with the computer at home. Go back home, unplug the internet or the router at home. You don't want to touch your computer anymore. It's mind-boggling. This is awesome because the only reason we started buying computers, using computers, was the fact that we could connect them together. And sure enough, if you look at all the biggest winners, they've been collecting and processing data about people. Whether that's Facebook, that does that to text and images, YouTube did that to videos, even in the computer nerd, sort of circles, there's things like that. So it's really just putting data together, creating single sources of truth. And the past years have created an explosion in AI. And these things are possible because there is a single source of truth. So what's mind-boggling is since 1960, we've created a single source of truth in literally every aspect of our life, but we just couldn't do it in healthcare. And it's staggering. So one thing I wanted to understand personally, the team that I worked with was, well, exactly how many of these silos are we talking about? Epic happens to be the biggest player as far as health data is concerned. So we started to measure the number of silos that are persistent in healthcare, and that number came out was staggering, 18,980. So we've got all these data centers, apparently, as far as health data is concerned, and they don't talk to one another. It is amazing, it is stunning, it boggles my mind, it truly does. And in fact, if there's one graphic that kind of shows what healthcare institutions generally do to data, they end up doing something like this. Just every time you're punching something into a computer, it goes to an on-premises storage location. If you're really sophisticated and you pay an arm and a leg for something like Epic, they're going to push it to the cloud. But then that's where it goes to die. So we've then created silos, centralized, each on-premise systems. But if you look at the totality of data, in particular as far as health is concerned, it has been exploding. In fact, we're at a point where the number of devices that are logging and are generating health data is mind-boggling. It's absolutely mind-boggling. And again, it sort of goes back to the 1980s. In many ways, what has happened to healthcare and computing and internet is we're stuck in the 1985s. We just haven't progressed any further. We were the earliest doctors, and this never progressed any further. So in summary, what's actually happening is patients are the ones who are suffering the most. The ecosystem is broken. If you're an analyst or someone working in AI, you have a lot of friends, folks who graduated from our institution, degrees in computer science, working as data scientists in places like Seoul, or what have you. These people are conducting experiments based off of, at the most, 11,000 patients, and that's all they can do. Because, well, if you look at what Seoul is doing this. If you look at what MD Anderson is doing, it is doing that. Our Cancer Institution is doing that. These people want to share data, but they just cannot or will not or are not able to do it. What's going to happen? What is the way out? Well, I'll briefly talk about three emerging pieces of technologies. Some of these things have existed, but a lot of these things are brewing and are about to come off in the next 2 to 3 years. And should they happen, it's going to change the game. What are those? One of the first ones is decentralization.
That's not blockchain. You don't actually store health data on a blockchain. That's crazy. No, decentralization is much simpler. Now, a piece of paper like this. I mean, if you use products like Facebook, YouTube, or what have you, if you're uploading your data, you're literally sending the entirety of your data to one server. Decentralization is different. What is decentralization? Well, what you do is you don't send one piece of data to the server. You tear this piece of paper out in, let's say, 5 different shards, and you put these shards in different places in this room, and only you know where to put the shards. Which means that you're the only person who can put the whole thing back together again. You want patients to be able to do that. You want patients to pull out their phone, push a button, it shards the data and it puts it all over the world the way only the patient knows what to do with it. These transactions are stored on a blockchain, but you don't put the actual data on the blockchain. You still put them on awesome servers, but we do it in a way that is sharded, it is stored all over. That's number one. Second thing, it's been improving in spheres of cryptography and that's fully homomorphic encryption. What does that mean? I'm going to say that in very simple terms. When you encrypt a piece of a document, you can't read it. That's the whole point of encryption. If you encrypt it, you cannot read it. What fully homomorphic encryption does, and some of these techniques, is you encrypt a piece of document, you still can't read it, but you can do mathematics on it, which is you can add 5 to it and ask for what the answer is. You can run AI queries and get answers without having to decrypt the data. This is revolutionary. We've been doing a lot in FT. In fact, our team and I have pushed the boundaries on what's even possible as far as FTs and stuff. It has its drawbacks, but it's revolutionary. And the third thing that's actually happening is because all this have a flow, what's also happening is these phones come in with a built-in wallet. Which means that if I'm a patient and I own some really amazing data that would save the world, I could, number one, push my data, decentralize my services, which means it's everywhere and really hard where they are. Number two, it is encrypted using fully homomorphic encryption. And then number three, because I have a wallet, I can start earning for my data. I'm giving it to the world, I'm giving it for medical research, I'm giving it for all kinds of things. And I can start earning. In fact, we've been busy building these things in Seattle for the past 6 months. What this amounts to is a patient single source of truth. Healthcare is a very complicated web of people, of value, and money that moves around. And in some capacity, patients get a bystanders. They get to observe, they can't do anything about it. We believe that the whole system should exist to service to them. And they're the ones who should run healthcare entirely. So effectively what we're doing is sort of moving away from centralized silos and moving more towards a model like that, where data is really everywhere, it's nowhere to see. Some of the things that we're building is something like this, which is we're creating population scale data. It's encrypted and sharded, it's moved all over the world. And then the whole market is not starting ready for like AI data, training models, answering questions. In fact, here are screen grabs from some of our earliest demos that we've been building. This is very oncology focused, which is you can have conversations with population scale data. It's really interactive. Quick is still 5 minutes per query, but these queries can generally take days, if not weeks, to figure out. And it's not just answering these queries. It's also coming back to plots, UX components that you can sort of use, export, and other fun things with. And while we're doing all this, we're also creating a very slick application for the patients where they get to collect, upload, and monetize their data. What this means, well, the funny thing is, when we started talking with providers, most doctors in particular, why would you want to share your data? The number one pushback that we often get is, we're going to lose our patients. And that creates this really weird dynamic in the sense that they're unwilling and unable to share this data. But yet they understand that if all this data could exist in one place, miracles can happen. But anyway, whether it's securing or future-proofing your infrastructure, getting full patient journeys, even earlier, because you switched to a service like this, all of this is on the table. Anyway, so what is next? I'm just going to end this with a story. I was reading this the other day. There was there was a hiker who was lost in the Appalachian Trail, and the man was really thirsty. He was really thirsty. It's Tennessee. He wakes up early in the morning. There's a lot of mist in the air. There's lots of mist. The man's thirsty. He has to have a cup of water. He pulls out a map, a hand-drawn map, and he realizes there's a pond that's 1 mile away. What is the hiker going to do? Well, the hiker's obviously going to walk to the pond because he can't drink the mist. And ponds are interesting because ponds, by definition, cannot share water with another pond. They're just their ponds. And if you're a hacker and you're thirsty for data, you're not going to look at mist. You want to hit the ponds, obviously. Whether it's savings healthcare or even the things that happened yesterday with Cloudflare. These are examples of what happens when you put stuff inside of ponds. They're easy to find. What we want to do, what we're in the business of trying to do, is we're trying to convert every pond in healthcare into mist. Mist sounds awesome, but the problem is you can't drink out of the mist. So we go one step further in the sense that we allow patients to push a button, and we're able to convert mist into clouds and clouds into rain. So if you're a hacker, or if you're a legit person who wants data for medical research and advancement, and you're out of the forest looking for water, all you really have to do is swap some queries to the protocol auxiliary. We convert the mist into clouds, and we create rain for you no matter where you are. So our mission is to really create mist to cloud centers. And so why am I doing this? Like I said, I've spent my time spending, bringing these technologies to where we fit back to New York City. There's a bunch of buyers. So why am I doing this? One of the first students that I worked with as a professor, she died of cancer. This is 5 years ago. It was a very emotional time because we spent a lot of time working on all kinds of amazing things. But the past year, though, has been a little bit more personal. My dad was diagnosed with cancer, and you just look at these things and you understand how broken they are. And you also understand that people who have deep knowledge in technology, they were constantly these miraculous things. Amazing things can happen. So that's why I do what I do. Unfortunately, I have met Cynthia Olick a while ago, who introduced me to healthcare and all of the sort of complexities that that make up healthcare and what they are. Also been fortunate to speak with or need to know apology. So I'll keep the talk short. And I would love to learn from you. So, if you have things to teach me as far as healthcare is concerned, all ears. And if you have questions, I'll take this.
Are you into cardiology at all?
To me, cardiology and oncology or hypertension are really the same to very but as far as data is concerned, it's the same. You can do this oncology, you can do this cardiology, you can do this hypertension, you can do this Yes, please.
Thank you so much for an excellent talk. I was wondering if you could speak a little bit to some of the unique cultural considerations around sharing of data in the US, and specifically privacy and cybersecurity concerns, because in Europe, they've successfully achieved a lot of this already, right? In France, people can carry around a card that contains all their health information, they can control it, so it's patient controlled, decentralized, as you described. Yet in the US, where we're in such a polarized society, I could imagine that we might have individuals and individual populations that are deeply concerned about where their healthcare data is going to go and who's going to see it, and therefore it might be difficult to achieve unity around promoting causes like these.
Excellent question. So we'll do answers to that. Number one, even if you don't have cancer or anything horrible, even if you're writing an ordering, something as lowly as that, what's happening to your data is hacked, abused, and stolen every single day. It is monetized every single day. You don't earn a dollar of it, which is sad. Second, as far as security and compliance go, spend a lot of time understanding what that is. Products like these don't just encrypt data, they encrypt and shard them, which means they're broken under small bits and they're thrown all over the world. So in theory, even if one were to hit a bomb, so to speak, a cat bomb, they're going to get a fraction of the data, and it is encrypted. It's mostly garbage. So even if you hack it, you're not getting anything. But if you don't take my word for it, you're going to believe me. Let's understand the fact that no one's actually been able to hack something like Bitcoin. It's out there, it's a taunt, it's the biggest FU every government in the world. Why is that so? It is so because the amount of computation you need to compromise every node in the network. We don't have enough computers in the world to be able to do that. And I think people's eyes are going to light up when they realize the kind of money they can make, especially in oncology. Cancer data has to be some of the most valuable kind of data. And our estimates indicate that if you have oncology and you're on a product like this, you're earning anywhere from $1,000 to $1,400 every single month just because it's out there. In fact, the numbers can add up to a point where you start questioning the sanity of A-grade health insurance. These are compelling reasons to sort of start looking at this. And also, because the whole product is sort of patient-centered, they get the option of saying yes or no to specific needs. And if it's a no, it's a no. You're never release.
He is actually a medical, he's an early individual from Jawaharlal Institute of Postgraduate Medical Education, we call it START, and his alumni seems to be here, like Dr. Nani. So, he's got a lot of followers in the room. He has multiple appointments and he's written multiple academics, he's been in academics, he's still in academics in the AAPI system. And he has helped us a lot in organizing this CME. So thank you, Dr. Namaste, and
thank you, Abhi. I think let's get started. This 2 p.m. slot is a very tricky slot. It's a very sleepy music. And I hope I will continue to sleep and put myself to sleep. But let me get started. Looking around the audience, I know you're a very small audience, but am I right to infer that most of you are Indians, are of Indian origin? Am I right? Yes. Yes. Okay. Then am I also right to infer that most of us carry the perception that we are not really prone to colon cancer? Right or wrong? Wrong. So this is partly true and partly not true. And I hope by the end of my talk, I will have got more clarity to this country. This shows the cancer burden in the United States. Colon cancer is the fourth most common cancer in the United States. It's a deadly killer. About 50,000 patients are estimated to die from colon cancer in 2024. And nearly 153,000 cases will be diagnosed in 2024. It is the third most common type of cancer in both men and women, the third most common cause of cancer-related mortality in men, and the fourth most common cause of cancer-related mortality in women. Most of these cancers are sporadic. What do I mean by sporadic? That there is no family history, and they don't fit into the typical syndrome patterns. About 70% of these are sporadic. About 10% of patients fit into a typically inherited predisposition to CRC like syndrome, FAP, MUT-associated polyposis Lynch syndrome. And another 25% have some sort of family history or the other. But the most important thing you need to know about colon cancer is that this is an eminently preventable disease. So what I'm going to do is, I'm first going to give you an overview of cancer in the United States, then compare it to colorectal cancer in India, and then finally conclude to emphasize what ails the South Asian community in the United States. See, most cancers follow an adenoma-carcinoma sequence. That's about 95%. Only about 5% are proteinable from non-liquid. So what do you mean by adenoma-carcinoma sequence? That the evolution of cancer from normal epithelium goes to an intermediary phase called the adenoma. And this is affected through a series of mutations occurring at different levels. At the APC level, that's the adenomatous polyposis coli, the KRAS oncogene mutation, and the P53 tumor suppression gene. This is nothing but a cartoon depicting the same process. You have the normal epithelium here, and it takes about 5 years to reach a small polyp or an adenoma, and another 5 years or 10 years to reach a large adenoma and then a colorectal cancer. But not all small adenomas will grow to become an adenoma or a cancer. And even the time frame will vary depending upon the type of mutation that occurs. If there is chromosomal instability, the pathway can take up to 10 years. But if there is microsatellite instability, it can occur faster. But the most important thing to know is that if we can detect these adenomas in a timely fashion and remove them, you can prevent colon cancer. Now, coming to the current incidence of colorectal cancer in the United States, it ranges between 35 to 41, depending upon whether you are male or female. Then, if you analyze the incidence age-wise, you find that a significant number of patients are over 65 age, and about 32% are between the ages of 50 and 64. Remember these figures when I show you the comparison to Indian figures. So almost 88% of our population who develop colorectal cancer are over 50 years of age. And the mean age of diagnosis of colon cancer in the United States is over 60. It used to be about 65, and now it's come down to about 62 or 63. Now, this was not always so. In the past, for example, in 1985, the incidence of colorectal cancer was almost 80 per 100,000 of the population. But over the years, this has decreased to what we see now between 35 to 41. Now, why is this so? That is because we have effected a very strong, aggressive screening colonoscopy program. But our program has not influenced people uniformly across all age groups. Because if you look at this slide, I know it's a very busy slide, concentrate on the age group 20 to 49. The incidence is actually increasing. Okay? But when you look at the age groups 50 to 64 and the age group 65 and above, the incidence is going down or is almost flat. Again, why is this so? This is because when we implemented the screening colonoscopy program in the early 200s, we used a cutoff level of 50 years of age. We did not include patients below 50 years of age, and that is the result of that. So this is what I was saying. Now, these are the colonoscopy screening rates in the United States. In 2012, it was 65%, and now it reaches about 70%. Again, as I said, when you break down the screening rates age-wise, you'll find that in this age category, 45 to 49, it's only about 20% rate, while in the higher age groups, it's about 59 to 60. The figures are a little bit different because these are two different groups monitoring this screening rate. Okay, these are the stool-based tests. The fecal occult blood, which we used to do earlier on, did not differentiate between human blood and animal blood, and so diet could influence it. But the fecal immunochemical test is able to differentiate between the two, and you don't have any diet restrictions. And then you have the FIT DNA or the Cologuard. And as I said earlier, that all tests are beneficial. This is the only randomized clinical trial showing the impact of colonoscopy screening on the incidence rates of colon cancer. This actually comes from Poland, Norway, and Sweden. And here the participants were randomly assigned in a 1-to-2 ratio either to receive an invitation or to follow a normal treatment pattern. The risk of colorectal cancer at 10 years was 0.98% in the invited group and 1.20% in the usual care group, a risk reduction of about 18%. The risk of death was also decreased from 0.28 in the invited group to 0.31 in the usual care group. This is nothing but a slide showing you the decrease in incidence of colorectal cancer. And this shows you the decrease in mortality from colorectal cancer. And as I said earlier, all modalities have been shown to increase the number of life years gained. If you look at, even if you do a fit test every year, the number of life years gained is 209. The number of life years gained is 292. Obviously, if you do a colonoscopy, it is much higher. But keep in mind these figures, and if you start screening at 45 years of age, it is even higher. The number of CRC cases averted, again here, all modalities show a definite benefit. Fit every year is about 47, and colonoscopy every 10 years is about 58. Number of deaths averted, again, if you do fecal immunoglobulin testing every year is about 25, and colonoscopy is 27. Not much difference, but I feel that screening colonoscopy is a much better test because you actually evaluate the whole colon and you have a therapeutic modality. But again, as you said, if your patients are hesitant, go ahead and do whatever is required. Okay, in summarizing, the current incidence of colon cancer in the United States is 35 to 40 per 100,000. The mean age is about 60 plus, and approximately more than 60% of cases are detected in patients 60 years of age or more. And there's an increasing incidence in the 40 to 49 age group. That's why recently we have dropped the cutoff level to 45 instead of 50. Let's move to India now. Now, can anybody guess what is the incidence of colorectal cancer in India? Any guesses from the audience? Speak up, anybody.
Couldn't get the data, couldn't get the data.
Yeah, but whatever you know about. Yes, what number did I hear? 5. Yeah, somewhere close. Very good. So, in fact, traditionally, we've never had any good studies from India. And so whatever is reported in the textbooks, they report an incidence about 3 to 3.7. In fact, this is a graph I picked up from one of the textbooks. And if you look at this slide, they referred only to Mumbai, India, and it's about 3.7 for males and 3.0 for females.
Dr. Kumasi, your cell phone is going off, I think.
I think it's ticker. I think these are all the messages from AAPI saying something is not going on. Yeah, they're saying breakfast. It's coming now. Breakfast at 8 a.m. to 9 starts tomorrow.
I got that message half an hour ago.
That was a good thing. I think maybe it woke people up. Okay, if you look at the cancer distribution of India, colon cancer does not rank among even the top 5 most cancers in India. Okay? It's not even on the list here. Rectum is somewhere, I think, about 8 or 9. However, there are other reports which claim that the colon cancer ranks about 7, is the 7th most common cancer in India. However, despite the low incidence, if you look at the number of new cases detected every year, it's about 65,000 cases, which is almost half of what is detected in the United States. So because of our large population, this becomes a significant number. And it is also the 4th most common cause of death due to cancer. And now, why do we have a low incidence in India? It could be underreporting, because our registries cover only about 7% of the population, while in other countries, registries usually cover at least 25% of the population. And India has a younger population. The demographic graph is skewed to the left rather than to the right. That could be the other reason. And it could be genetic or it could be environmental. But we don't have any clear data on that. This is a study where they published a report on the incidence of CRC in India based on population-based cancer registries. It was confined to a few major cities. And if you look at this, you find that the incidence of colon cancer ranges from 3.9 to, I think, Mumbai 6.3. Mumbai 6.3. So
it's 124% in Congo?
Yes, I come to that. And over the years, it has increased, okay? From 5.8 overall India to 6.9, Bhopal 4.5 to 5.5, Chennai 6 to 8.2, 35% increase. Delhi 5.4 to 7.2, 32%, and Kamrup is 5.1 to 11.6, which is almost 120 more. And there is something to do with the Northeast, which I'll show you in the next slide as well. See, Mizoram is the cancer capital of India. All types of cancers are increased in Mizoram. And even if you look at colon cancer specifically, this is one place where the incidence of colon cancer reaches almost 15 per 100,000 of the population. Again, the reason for this is multifold. It could be genetic, but diet seems to play a very important role. I'm not too sure, I'm not privy to this, but maybe if there are anybody from the Northeast, they do eat a lot of smoked food. Is that right? And then they said that there's something, a fermented pork called saun, which is exclusive to Mizoram and not commonly consumed even in the neighboring states. This could play a role, they feel. Okay. And the smoking habits. Mizoram holds the highest rate of tobacco usage among men and women across the country. Tobacco consumption in Mizoram encompasses tuber, tobacco-infused smoked water, and the use of non-filtered, locally crafted cigarettes known as Zoysid. So what we see in India is a marked regional variation. Now, what about the trends in colorectal cancer? This was a study which was published here in Clinical Gastroenterology and Hepatology. Wong et al. Studied the trends of incidence and mortality of colorectal cancer in 36 countries by reviewing data from registries. And among the 36 countries with population of all ages, 10 countries, all from Asia and Europe, had an increase in incidence. And of this, India topped the list with an annual percentage increase of 8.1, followed by Poland. Okay. But the probable fault with this study is that it focused on only one city in India, Chennai. But having said that, the overall message is clear that the trend is increasing. As we saw from the previous slide, Kamrup showed a 124% increase. Next, I will present you one or two studies which will further characterize colorectal cancer in India. This study comes from the All India Institute of Medical Sciences. They studied a total of 970 patients with colorectal cancer who were followed up by a computerized, comprehensive, structured CR clinical database. Of those 970 patients, 401 had colon cancer, but 569 had rectal cancer, almost 58% compared to 40%. While in the United States, it's the reverse. So almost 70% is colon cancer and about 25 to 30% is rectal cancer. Okay. And then look at the mean age of diagnosis, 51 or 45 compared to over 60 for the United States. This is another slide which shows you the presentation, which is more or less similar. And they say that the stages at which they are detected in India is probably a little bit much later. And the other difference they have looked at is that probably mucin-secreting adenocarcinomas and signet ring cell carcinomas are a little bit higher in India. This is another study from Tata Memorial in Mumbai. They looked at 800 patients. And here again you find that the incidence of rectal cancer is almost 54%, surpassing that of colon cancer. And this is the same slide of histology. Okay, I'll skip this. Okay, now look at this slide. You find that in the age group 20 to 39, you have 31% of patients with colorectal cancer, and another 1.5% below 20 years of age. So below 40 years of age, you have about 1/3 of the population presenting with colon cancer. And now compare this to the United States. You see about 88% is over 50 years of age, and only about 13 is below 50. And even if you say below 40, it will be less than probably 10%. You will see this marked difference in it. Now, why is there a rising incidence of CRC? It could be the diet. A lot of companies like McDonald's have come into India. People eat a lot of red meat, processed sugar, refined grains, high sugar containing diets. People in India usually don't exercise. I don't mean to be offensive, but that's what we have seen. Okay? And obesity is increasing in India. Smoking, there could be genetic causes. There are some studies which say that hereditary non-polyposis colon cancer or Lynch syndrome in the Western world is about 5%, and in India is about 10 to 15%. But again, here these are based on smaller studies, and I don't know how much to depend on. Okay, so summarizing, the incidence of colorectal cancer in India is increasing rapidly. It is a disease of younger people. The mean age is about 47 years. 33% are less than 40 years of age. And rectal cancer is equal to or more common than colon cancer, and it is histologically also more different. But what is even more disturbing is that there is no health awareness in India with regard to colorectal cancer. This study was conducted among medical students in Kasturba Medical College in Mangalore. And you find that although they had a very good knowledge about colorectal cancer, 94%, 92% of the participants were aware of the risk factors for CRC. Only 49% of the participants identified FOBT as a screening tool. And only 30.7% of participants knew that 50 years is the recommended age to begin CRC screening. So if medical students are not aware of this disease, then what about the general population? It must be even worse. And TV ads in India are more directed towards lung and oral cancer. I think that is acceptable because those are very high on the list. But they should also emphasize CRC cancer. And what is even more disturbing, as of now, there are no formal screening guidelines for CRC in India. The ICMR may come up with some recommendations in the near future. Poonam, do you want to say something?
Yeah. But is there, for a country like India,
right?
Is there actually any screening routine guidelines which can be followed? Because the problem is, one of the things which you have said,
right,
that colon cancer is preventable.
Right.
That slide was very strong.
Right.
I can understand that it can be picked up early,
right,
can be treated, can be cured.
Right.
But when there is a benign adenoma, you're saying adenoma to carcinoma the stage,
right,
how are you going to pick up that? I mean, it's we have 130 million, 1.3 billion population, out of which if you take the age group,
right,
since you are showing 20 to 30 years,
right,
it's impossible to have a screening program.
Yes.
So if you can have probably fecal occult blood test as a mandatory. Now, but that's being done. Every student who is going to attend college, there is a physical examination, urine and stool test. So each stage, when you are joining an office for your service,
right,
you have a medical test.
Right.
That medical test is a doctor's examination and a urine and stool test.
Right.
So a stool occult blood I can understand. But what you are saying, in United States, what's the screening colonoscopy guidelines, criteria? What are the guidelines?
See, in the United States, we recommend the screening colonoscopy as the first line.
For all patients above 45.
All over 45.
Can you finish your talk, sir? If I was sitting and talking, they would shut me down. At the end. Finish up the talk.
Sorry, apologies.
Okay, so let me continue, and Punendu, I'll come back and go.
Sure, sorry, my apologies.
No, I'm sorry, but
yeah. In fact, Punendu. Okay. In fact, you know what? What triggered my interest when Achintya asked me to give a talk here was I started researching this, and then I came with an idea of how we should tackle this, and that's why I'll answer your question later on. Okay? Right. And so I said ICR may come up with some recommendations later on. Okay. Now let's come back to the United States now. Again, I'm going to stop you again and ask you a question. What do you think is the incidence of colorectal cancer in the United States among Indians and South Asians? Give me a guess. Just throw a number.
2 seconds. The highest is the black people, it's next to the Indians and us, and third with the white people.
No. What was it? 2? Yeah, 2 is also not good. Anybody else? Any other guesses? 6. Okay. Yeah.
Don't say just because I'm a boss.
Maybe I have to say yes. Any other numbers? 8. Okay, you're somewhere close. See, what happened so far was that all of us South Asians were clubbed under American Indians.
How are you currently using AI to sort of help in your research, and how do you want to use it in the future, or what would need to change for you to use more AI and helping to predict these trends so we can act fast?
So as I showed you the last slide, we are using AI in some centers to pick up small polyps. But I'm going to speak very frankly, I have not found that very useful. But maybe the trainees who are just starting off may find it very useful to pick up these small polyps, and they may miss them. But by and large, most colonoscopies are done by attending physicians, and as of now, I don't think it has helped much. Although there are studies which say that it has increased what we use as a benchmark, the adenoma detection rate, and that prevents cancer. So maybe that we still have to refine the process. It may be helpful in the future.
So I guess when machine learning catches up,
And as a quick follow-up, South Asians are very underrepresented in clinical trials with only 2%, which is abominably low given that we make up 1/4 of the world's population. What are you seeing in terms of any movements to actually get South Asians connected to these trials early on? And anecdotally, off the record, do you think these drugs and these sort of, therapies that we're currently using for South Asians, do you think they work as well on South Asians as you're seeing them work on maybe patients who are white?
I think again the data is very, very limited. I think it is our community here, our physician, the AAPI and people like that, to create more awareness, and we've got to be included in more clinical trials to get more better information.
Thank you.
Thank you very much.
Thank you for all your comments and questions. So I have the pleasure of introducing my friend Dr. Abhijit Roy Chaudhary next. He's a radiologist, trained at UMass, trained at medical school at Jipmer, as I can see. Osmania. I was kidding. So he's representing the Bengalis and the Telugus.
Can't be the best, not the best quality in India.
No, I'm saving the best for last. I've got Aman sitting over there. Alrighty. So he's at the VA in Fayetteville, North Carolina, and he's going to talk to us about virtual colonoscopy, again, keeping the theme about colorectal cancer screening and how to get it done.
So I'm happy to be here because I am the National CME Chair, and it's a great audience here and very interactive. So let's move with this, and I'm doing this only because I had to follow a colorectal cancer talk. So no conflict of interest. And the main thing is, recently on July 11th, the U.S. Center for Medicare and Medicaid Services has backed the Medicare reimbursement for CT colonography. This is July 11th, and so I thought this would be a nice thing to do in this conference. And if you see here, this has been a long time thing. We have been doing this forever. We did a international congress in Boston 2005-07, and it's been going on from then, and nothing moved. So some of my slides are from 2008, and nothing moved from then. Actually, it got approved once and then again disapproved. So this is our issue. And then, as you see, this is something that we need to do, and is one of the good things that has come up in screening. Now, this is being discussed, so I won't go too much. But our organization, the American College of Radiology Imaging Network, we did a trial in 2008, and we proved that it was equivalent to optical colonoscopy. And everybody knows the difference is that you cannot do a biopsy. That's the main thing. But CMS denied it in 2009 and had continued to do so till now. After CMS, in present now, suddenly the CMS says CTC is reasonable and necessary as a CRC screening test, especially for patients, clinicians who seek a direct visualization procedure as a first step in CRC screening that is less invasive and less burdensome on the patient and healthcare system compared with screening colonoscopy. So what's happened is, optical colonoscopy, what's happened is,
we were only given clearance for diagnostic CT colonography, which means if a patient goes to a screening colonoscopy, optical, and they fail to see the entire colon, they would come to us for CT colonography. That was the only time we were paid. But this thing clears us for doing a first study. And believe me, George Bush Jr. got it, Obama got it, and Marco Rubio actually openly said he loved it. So, but the point is they have a healthcare that allows them to get anything they want. That's the senators and the congressmen. We don't have the same healthcare. So what I really say is we expect that clinicians who order CTC for CRC screening will educate their patients on risks and context of radiation exposure and potential extracolonic findings. So what happens when we do CTC is that we find, most of the people say, oh, it's radiation. So that's one thing. Secondly, they'll find a lot of extracolonic findings, small little adenomas in the adrenals, stuff like that. And then they go on a workup for that. And they have clearly said they clearly said that coverage for CTC for colorectal cancer screening would replace barium enema screening. People still write barium enemas after there is a failed optical colonoscopy. You can't pick up, forget 10 millimeters, you can't pick 10 millimeters, you might pick it up, and it has to be a very good radiologist who's already trained, has been doing that same thing forever. I used to do a good double contrast. I can't do it anymore. It's just difficult. So, this one we talked about is that why we do, and everybody knows why we do it, because it's got a long period in which it can be detected and then cured. So why CT colonography is our question, right? Because if you look at we are talking about 2007, we are talking about that time, we were allowed only, till even today, except Medicare, we are allowed only in failed and incomplete colonoscopy. Local coverage determination like Medicare can, in 46 states would decide. You have to go on phone calls after phone call. Colon screening, unable or unwilling to, so you can only do it if it's unable or unwilling to have optical colonoscopy. Even then, only a few private carriers would have covered us. Self-pay is okay. It's okay for, you can get whatever you do as long as you pay money for it. We at UMass decided at $700, and we had no one picking it up. Because the doctors don't, the physicians have to be comfortable first. What the physicians do is they send it to GI, and the GI obviously won't want another, let's put it, another department getting, even within departments, even in the hospital, there are these money-making areas, right? So there is all this thing where GI can make more money because of the endoscopy suite cost, the anesthesia cost, and all that. So there is something there going on there. But look at the study. Sensitivity per adenoma, 8 millimeters, we're comparing two sizes. Virtual colonoscopy is detecting 94%. Optical, I mean, this is just a part of that thing. It's not like the same, really. And 10 millimeters optical, same. And I'm talking about 2003. At that time, scopes had only one camera, which would go forward. Today, it's different. I'm sure Dr. Gumasi will be able to tell you that they have retro cameras. When you come back, you can see the other side and all that. That time, it wasn't there. So their detection has improved now, but still we were comparable at that time. Specificity on VC is virtual colonoscopy. We used to call it virtual at that time. Then they said, if it's not somebody came up with saying, if it's not a true colon, it's a virtual polyp, so we had to change it to say CT colonography. This is not a virtual study, it's a real study. And so we changed the name to CT colonography, but it's the same, 92%, 96%, but 55 additional polyps were found by virtual colonoscopy. One cancer was missed by optical colonoscopy. But I'm not saying that it's a miss or something, because it was a different grade of colonoscope that was used at that time. Now, this is not radiologists always showed poor results. So these two are not radiology studies, but Perry Picard is a radiologist, and the same data that I presented before. Somehow, their detection was less, and we said that was because they were not really trained to read CTCs that much. Then, again, November 2006, Perry Picard moved from the defense, DOD, to University of Wisconsin, and he somehow managed to make the university do CTCs, and all of their staff would get screening CTCs first. And then there was No. So if you see, the 6 millimeters, greater than 6 millimeters found in 990 patients. 10%, no polyps were found that was greater than 6 millimeters. So 89% of the population did not really need any optical colonoscopy. And again, you have the numbers, 3.9%, only 3.9% of the population had 10 millimeters and above, and 6.9 had between 6 and 9. And then this group was allowed to choose optical colonoscopy, and 40% of this population chose to go for optical colonoscopy. So our referral rate of OC referral rate is 6.4%, don't bother about it. Lesions that were found, like when they did optical colonoscopy, they found that 91.5% positive predictive value, which means when we said that there was a polyp, there was a polyp. So the advantage of doing this thing is you prep the patient and you do a CTC. If you see a polyp, same day you can do the optical colonoscopy. And so it's called the same day CTC OC was performed 61 of the 71 patients. 86%, that is 86% of the population of the patient got the CTC optical colonoscopy on the same day. This is the University of Munich. I won't go too much into details except that equal performance for relevant polyps. Both CTC and OC, optical colonoscopy, performance were nearly equal. Large, if the polyps were large, there was 95% probability of picking it up. This is our main study, which was done in the United States, that changed a lot of things. 15 centers, 2,600 asymptomatic patients for colonoscopy. Symptomatic or high-risk patients were obviously excluded. And then we did a endoscopy with standard lesion matching protocol, which means when you say whichever area we say, you do a mark that area on CTC, so the optical colonoscopy can be done at the same location. All you do is cathartic prep, fecal and fluid tagging, CO2 insufflation, IV glucagon. This is how you do it. No anesthesia anywhere, nothing. You have to use a 64 slice. We could do it on 40 slices, but 64 slices is better. Now you know there's not standard CT in most of the institutions are 120 and above, So you don't even bother about these 64 slices is very standard machine these days. All you do is use a low dose technique, 50 milliamperes per second, and you can interpret it by 2D or 3D review. I'll talk about it if anybody wants to know about it. This is mostly a radiology thing. And you have to have formal reader training and rigorous test-based certification. If you don't, then you'll get a study like we showed before where the pickup rate is poor. And look, the key results from that is that of the 2,531 patients, you can see that it should be less than 5 millimeters, it's not greater, less than is 547, 6 to 9 is 392, 10 millimeters or larger is 155 patients. And so what's happened when you calculate that is 10 millimeters is 90% sensitivity on 10 millimeters and greater polyp. This is also an important thing. Negative predictive value was 99%, which means if you say there is no polyp, there is no polyp. And that is where screenings are helpful. If you say there is nothing there, you don't need anything further. So advanced adenoma, which is the 10 millimeters or greater, was our market is only 4.3%, which really needs an optical colonoscopy. 8.3% of patients will have optical colonoscopy if 6 millimeter cutoff was used. Even if they use the 6 millimeter cutoff, below 5 we don't even report. Then only 8.3%. So not more than 10% people really need optical colonoscopy. Let's go forward. I don't want to go much on it except that I wanted to talk about the 99%, and this is an academic slide, negative predictive value there, high. And the other thing that can happen is if people don't want to get an optical colonoscopy, you can show them an image of the virtual colonoscopy and show them this area, and they'll get their whatever is needed. It's like it helps them understand what it is because there's an image there. So target screening, we're talking about this less than, so we don't even talk about, okay. So polyp size 10 millimeters or greater is less than 5%. I won't get into this slide. This is probably not a little political there. So, when is a polyp not a polyp? So if you look at this, so when is a polyp not a polyp? The point is, when is a polyp that needs to be done something versus just it looks like a projection? And that's because if you look at this, less than 5 millimeter polyps, they are more non-adenomas, while they are 40% is adenoma, less adenoma. 60, as it grows in size, it becomes an adenomatous polyp. Because you can have hyperplastic polyp, you can have lymphoid follicles that look like a growth, you can have non-specific inflammations, you can have normal mucosa that might be a little more projecting, and for a colonoscopist, they don't want to take a chance. They'll just take the biopsy, 2 millimeter, 1 millimeter, just projecting out, they'll take a biopsy. Because they're there, and we don't blame them for that. They're there, they're looking at it, they're like, I don't know what this is, let me take a biopsy and send it. And the pathologist will be in the room, will be better, will let us know what exactly it is. So, our question was, do the carriers know what they are paying for? I did something. Do the insurance people know at that time, but now at least the Medicare knows. As we go along, as you have seen, there are studies after studies, I won't go into each one of them, and you can see easily, because you're getting two views, one is endoluminal view and the regular view, you can see that there is wall thickening and narrowing of the lumen here, and that's how you'll see here on the CTC. You can, I'm showing you a diverticulum, it looks, so here you're seeing some opening in the wall and you don't know what it is. You look at the rendered images and you can see it's a diverticulum. The ileocecal valve, all gastroenterologists know that they have to look at the ileocecal valve, otherwise they'll say it's an incomplete study. And for us it's easy, and we just look at this is the way you would look at it probably and say this is ileocecal valve. We have a confirmation on the CT. A nice picture there. Okay, this one is there because it's an AI conference. I have to put this. Machine learning based differentiation of benign and pre-malignant colorectal polyps detected with CT colonography in an asymptomatic population, a proof of concept study. They have shown with AI that machine learning based analysis enabled non-invasive differentiation of benign and pre-malignant colorectal polyps with CT colonography. So now you have one step ahead. You can do AI and say, hey, do I got to go and take this 6.9 millimeter, let's say 6 to 9 millimeter. I'm not talking about 10 millimeters and above. 10 millimeters above, I want whoever can go in and take it out. But 6 to 9, I'm saying, hey, we can use this and say, this is benign. Maybe it'll take time for us to validate that, but it's there, it's in the process. Hey, thanks to you. Thank you all. Questions?
Thank you, Dr. Abhijit.
I'm waiting because in my hospital, my gastroenterologist walked out on me. So.
My name is Shashi Kumar. I'm from Pittsburgh. In your indication, I'm not sure, did you put it, a patient is a high risk for sedation, there will be another good indication for this procedure, like they cannot have sedation?
Yeah, so that's a clinical, so that's a clinical thing, that anything that the patient, all the doctors, they feel, but in earlier, if they were not, even today, if they are not Medicaid, only July 11th has cleared it. Before that, they had to call, your pre-authorization. I don't know if you have, how many people you have for doing pre-authorization, I have no idea. But that's the toughest part in getting any study done.
I agree with you about the air contrast barium enema should be out. We should not do it that. And also, I think I feel uncomfortable if I leave 6 to 9 millimeter polyp and tell this patient is benign. I feel not comfortable because we know that we have a miss rate of small polyp in the study.
No.
So still, I'm not sure I will do as a first line study as a 45 years old healthy patient and tell you want to go this test or that. I still prefer the colonoscopy, the best.
Yeah, so that is why it's a hard thing to break. It is not just the gastroenterologist, it's now the primary care. Even the primary care has to understand this. So we have done this sort of thing. We have to do a road show. So maybe this is the first road show after July 11th, probably the first after Medicare has approved. Yes, any next?
Thanks for the talk, Doc. Two things. First of all, going back to his 5 millimeter and less polyp could be adenomas, and those adenomas will also, 40% you said, missed polyp adenoma rate was 40% on CT colonoscopy, which will be pretty significant, thinking they also, in 10 years or more, will turn into probably a cancer syndrome. Secondly, colonoscopy prep is a major issue. Most of the people who, in this country at least, who talk about colonoscopy, I'm not going to drink the prep, number one. And some of them, talk about pain, etc. And I have seen the CT colonoscopy, when we don't succeed on a colonoscopy, very few, they go for CT colonoscopy, they do complain about that air distension of the entire colon with the CO2 or air. CO2, of course, if the reabsorb faster, it's better, but there is discomfort factor there. Thank you.
Excellent, thank you.
No, thank you, Abhijit.
My question is, this colonography, does it detect the intramural submucous?
Absolutely. Because a colonoscopist will look at a submucous lesion, but they don't know whether it is lipomatous or it is totally solid, in the sense that it needs some sort of margin is not okay. They can't do a deep biopsy. They're always afraid they'll perforate. So deep biopsies, I believe some people do, some people don't. I mean, Dr. Gumasti would better answer that.
So, in the interest of time, I think we're going to keep it short. And thank you, Dr. Abhijit Roy Chaudhary is not going anywhere. We need him tomorrow also. So, and this is a topic that we'll hear more about. Thank you. So, I actually had a timer started. Alrighty, who wants to take a drink of water? I see some people are kind of, I think we'll just knock off the best for the last. And I'm not just saying that because Aman is a classmate of mine from Maulana Azad, but just because he's a phenomenal person. So let me introduce Aman Mahajan. Dr. Aman Mahajan is the chair of the Department of Anesthesiology at UPMC. He came to UPMC from David Geffen School at UCLA. He's a scientist, investor, leader. He has done a lot of things that he's going to be modest about, but I don't have to be, right? I have to be proud of my classmates. I have two proud classmates of mine from Maulana Azad, Aman and Sibal, Anupam Sibal sitting there. He's a Anupam, yep. He's the CMO of the Apollo Hospital Group based out of New Delhi, the Indraprastha Apollo in New Delhi. So, do we have his slides ready?
Thank you, Indrapal. And thanks everybody for sticking around. I know I'm probably the last person that's standing between you and the social event, so please don't hate me for this. I'll try to make this thing interesting enough and general enough so that it applies to everybody. And thanks to AAPI and Dr. Malik for having me share my thoughts and some of our work that we've done in this particular space. My obligatory disclosures over here. Much of my research and work is in developing AI models, technologies, biosensors, wearables, which really are supporting digital health. And then I work as an investor for UPNC, for our commercialization unit, that's the enterprises. None of what I'm going to talk about are things that we've invested in, but we'll discuss all the scientific data on applications that are there in digital health. So, given that the theme of the conference has been AI, and you've heard many of the talks thus far already on what is AI and what are different types. There are many different ways of classifying AI, and we're not going to go into that. But specifically, there are many techniques in those that apply those principles, which are shown on the left over here. Be those machine learning, speech recognitions, computer vision, that's a big one that's coming in this particular surgical field, natural language processing, expert systems, and robotics. And you'll hear some about robotics in surgery tomorrow morning with Dr. Faz Bora. And on the right is what constitutes as digital health, right? So you've got wearable devices, telehealth, telemedicine, mobile health applications, smartphones, and mobile devices that serve as platforms, including AMR. And these are essentially enablers, technology enablers that extend healthcare. So as you can envision, AI needs digital health technologies, and most of these digital health technologies today, not all, but most of them are actually embedded with AI, some sort of an AI, and extending healthcare to the masses, and pretty much all fields. Some fields like radiology have been on the leading edge of the curve, and they've become more mature, and they've got lots more clinical trials. Some are lagging, and surgical services are somewhat more on the lagging end. But given the scope of surgical services in the United States and the rest of the world, most of the investments right now is going towards there. So that said, all of you are familiar with this particular data showing the mortality per year for different clinical conditions. Most deaths in the country and as well as the world are secondary to heart disease, cancers, stroke. But what we actually haven't recognized or openly acknowledged is that surgical complication rates, these are major surgical complication rates, they actually haven't changed a whole lot in the last 20, 30 years. And the 30-day mortality after surgery remains very high, to the point that if post-surgical deaths were actually a category unto itself, it would actually constitute the third leading cause of death in the country and the world. So, when Wall Street's reported, it's either because it's a big problem or there's actually a lot of money that's getting invested in it. In this particular case, it's both, right? So this is a technology built by surgical safety technologies called OR black box. And as the name suggests, and what black boxes do for aviation, they record all the events and the data that for which you can actually recreate everything that happened during a flight. So in this particular case, these technologies are embedded with fairly sophisticated sensors, computer vision, and advanced AI analytics, and pretty much capture everything that's happening in an operating room, and every physiological data set or every other movement, as well as team interactions that are happening between this complex unit that works. It's all captured in real time, as well as you can look back and derive insights into this. Now, what it shows is, and again, it's totally de-identified, and the individuals are essentially converted into their avatars, and as you can see, it's able to record, situational awareness that's occurring between different individuals. For example, here it notes as it's recording in real time that the trainee pulls a needle into a 5mm trocar. That's actually deemed as a threat during that particular procedure. And then what should be the response of the staff or the faculty who's overseeing that? And it essentially demonstrates features of resilience or teamwork, which can be captured in here. And those go a long way in terms of building increased capabilities of teams, as well as advancing the field of surgery. So a lot of what's happening in the operating with technologies like these, while the technologies are mature or getting mature, clinical evidence is, through trials, is still being developed. There's plenty of anecdotal data and small reports, but the clinical trials are still actually under development. This was one of the first trial using this particular technology that was recently published. And as many of you know, checklists similar to what exists in aviation have shown to reduce the complications and improve patient outcomes. And while WHO, World Health Organization, has promoted its checklists, which should be universally applied across all countries, every operating room, the truth though is that they're actually not adhered to commonly. And a variety of reasons for that, because they're clunky, they're not as easy to implement, and there are local culture and practice issues as well. But of course, using, as you can see over here in this cartoon, computer vision, acoustics, audio signals, and being able to determine the actual implementation of this, ensuring compliance. This particular study, which was done in 7 North American hospitals, includes some hospitals in Canada as well, over a period of 18 months showed that the compliance on the checklist was actually better when such computer vision technologies were used. So, as you saw just in the last few talks as well, AI and AI-based methodologies are getting incorporated within the operating rooms. This is just an example of which you saw before, deep neural networks. Again, these These networks have been trained on thousands of images of picking up adenomas during a colonoscopy. And I would actually contend that, yes, it may not be better today as to the best experts that exist over here, and there are several eminent ones over here, but they actually are getting better than most of the general physicians who are actually practicing this thing. And AI technology is just going to get better. And I think it serves to, it's not going to replace humans, but the humans, the physicians who are actually using this would be a lot more adept at managing their patients. Others, as you heard yesterday, in radiology, as being one of the leading fields here, this is again using a three-dimensional CNN, convolutional neural network, being able to diagnose as in preparation for the surgery, patients who have pancreatic adenomas, as opposed to a conventional image technique. AI certainly has infiltrated into the operating rooms in terms of creating temporal alignments of what needs to get accomplished during a surgery, so you can have that framework which would be available through computer vision, or giving better spatial context and conceptual context of how a surgery should be performed. And you'll hear a lot more about this tomorrow in the talks on robotics. And robotics in particular actually is lent itself very well to improvements through AI, because it can actually enhance the surgeons to make them super surgeons. I imagine all the surgeons, Indian surgeons over there, fall into the category of super surgeons already. But for many others, the surgical approach can actually be further enhanced by the by incorporating human robotic interactions. Particularly the perceptions and localization and mapping, those features will enhance the robotics. And then if you can envision an operating room, and this is kind of where AI is actually taking a strong foothold. There are human elements, there are the technicians, the surgeons, the anesthesiologists, and the other physicians who might be in there. But then there are actually all these monitors and all these machines, and this is a fairly data-rich source. And all of that today is actually getting incorporated and captured into some data stream on which AI analytics is deriving great insights. So what I want to focus the rest of our talk is really around the challenges that exist in the greater perioperative period, where there's more mature data and evidence to suggest AI and machine learning and digital health has actually improved outcomes. Many of you are probably familiar with this, that yes, while operating room, events in the operating room can impact care and outcomes afterwards, but also the events leading up to the surgery and as well as afterwards have equally, perhaps even more so, impact on the outcomes. Today, in most, even the best of centers, the care that's rendered is fairly fragmented. Suffers from poor coordination and poor communication across different disciplines and units. And despite a large body of evidence that supports that surgical optimization is a driver of outcomes, 50% of surgery complications are preventable, and 50 to 130% of them, more patients going home as compared to going to long-term care facilities. Finally, again, digital health and AI, it goes a long way in terms of improving access, engagement, and care delivery. I think one of the barriers for implementing AI and digital health technologies is, or many of the medical treatments and therapies is patient engagement, right? So we might have the best prescription, we might have the best insights, but patients just don't want to engage or follow. So, as part of our thesis development, again, in my role as an investor and developer, we study the landscape nationally, and this is again a summary of our thousands of patients that we spoke with, and several health systems, large health systems, small health systems, individual surgical practices. So there's a patient view and there's a clinician view, right? So patients feel that there's lack of clear direction. There's little tailored guidance on surgery itself, right? And that's not a lack of intention on the part of the surgeons or the anesthesiologists or the hospital. Patients actually don't appreciate what their own risk level is. But once you actually tell them, they actually say, we can actually institute short-term behavior changes. It's feasible, but we don't understand the surgeons or the physicians' orders or goals for them. And we don't actually have the support systems to make those interventions, right? So these were insights that we developed. All we're seeking emotional support, motivation, and shared accountability in order to get better. Okay? So when you ask the physician side, the health system provider side, they all said, basically, they just don't have the bandwidth. They want to do it, they recognize it's important, but it's just impossible. They also had a lack of visibility into what patients were doing. So they said they just write a prescription. They hope patient does it. We have no idea if it was actually being accomplished. Patients often forget pre-op instructions. Physicians acknowledge they rely heavily on nursing teams, so they also say that they're also stretched thin, right? And then there's genuine skepticism that patients will actually undertake behavioral modification to lower risk, right? So that's quite in contrast with what patients feel, right? Patients feel they actually can do it, but they need motivational tools. And the physicians feel the other way. So, right, so we said we can actually help bridge that gap through AI and through digital health tools here. Now, we're at a good time in terms of how smartphones and technology has been adopted across general consumers, right? So if you look at, and this is actually already dated, it's 2021, right? Just 3 years since there's even a higher percentage of different age groups that is actually owns and uses a smartphone. So if you look at patients who are in age 50 to 64, 83% of them own a smartphone and use a smartphone. That's higher now. And that's the age, as I mentioned to you, that's your median, that's the most one that's having most surgeries. And the millennials are actually falling now in 30 to 49 age group, right? So in the next 10 years, they would be actually having surgery. That's the generation that's already used to, I need the service when I need it. It's just in time, I need service, right? So they expect the healthcare to actually go that same route, is to be able to get that when they need it. So there's several different applications that have been developed. One's into a digital health platform, Seamless MD. Again, validated trials on that using digital AI and clinical pathways and programs that embed many of the data insights using machine learning. They guide the patients. These are SaaS solutions, so software as service. And some of them are actually software as therapeutic. And they guide the physician, the patients rather, on accomplishing the right tasks and following the right pathways prior to surgery. And this one being used in gynecological oncology patients, close to 700 patients in this particular study, lowered the readmission rates as well as length of stay for these patients substantially. This is another one where we were involved. We actually developed this technology. Again, I always feel that it's not digital health alone, but it's digital health interfacing with a human being. That's what patients want, and which is quite evident to us in our surveys. And here, while the patients do get guided with chatbots or with digital applications, but you actually have a human at the other end for the ones to provide the health coaching, the guidance that's needed. We can distill and break down all these protocols into simple steps that need to be accomplished every day. So to keep the patient's compliance high and engagement high. And of course, as opposed to studying in gynecological patients, we looked at orthopedic patients and general surgery patients, and similar to other results showing a substantial reduction in length of stays, readmissions, cancellations, Net Promoter Score being high, as well as patient experience being tremendous. When we ask the patients in terms of their experience, 95% describe being satisfied or very satisfied, and in fact 90% of them prefer virtual visits of that. And even the elderly patients, 75 and older, actually found the tasks to be easily accomplished or relatively easily accomplished using those digital platforms. And that goes to the better and recognition of human factors that go into designing those. So those applications are a much better design. So again, this might be might concern some of you, but this is again to show that surgery can be accomplished even without seeing a patient first, right? So it's possibly not for every patient or every surgery. And here we've created a total telemedicine pathway where you don't see a physician. You don't see a physician in person prior to surgery. So patients are seen virtually, they're managed virtually, and if they fall into a certain lower risk category, the first time you see your surgeon, the anesthesiologist and the physician would be on the day of surgery. It's not for all surgeries and not for everybody, but this is what we published. Published in JAMA, more than 1,000 patients, and we've continued this program for bariatric surgery, and essentially showing no difference in outcomes. In fact, you actually have a much better benefit in terms of carbon footprint for patients who don't have to drive and come to our hospitals. You all heard a lot about generative AI, right? So let me just show you a conversation that's occurring with a patient about their surgery. Doctor says, hello, this is the aspect of engaging a patient and informing them about their surgery and getting a consent. I understand you're scheduled for a laparoscopic chole. Is this a good time to discuss this? I want to discuss your risk, benefits, and alternatives. Ask any question at any time. And patient responds, let's go over the potential risk of the procedure, there's bleeding, and then blah, 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 all those. And do you have any questions about the alternatives? It sounds like you've made an informed decision. I need to confirm that. You understand the information provided to you. And I'm available, and our team's available to answer any further questions you might have before a procedure. And then finally, doctor, you're welcome. Any other questions or concerns, please reach out to our healthcare team. They're here to help you. And best of luck for your surgery and recovery. That seems like a very good interaction that occurs in terms of explaining surgery, obtaining a consent. Simplistic, 6th level, as it should be required, is deemed. What if I was to tell you this was actually done, not by the doctor, but by the chat by AI? This was an avatar of a physician who was talking to a patient and giving that information. Think about this, right? It actually has all the key elements that are needed in a consent. And it includes empathy. You ask me a question 10 times, I'll give you the same answer with empathy as compared to getting irritated. And it thanks you in the end, right? It shows the element that AI is getting evolved to the point where you can do this. Oh, this is not actually just this is actually a real instance, but there was actually a study done on this as well, which was recently published by at UCSF, where they showed that AI-based chatbots were using the large language models or generative AI performed better than surgeons themselves who practice this. Now, of course, it doesn't apply to any of the surgeons over here, but it shows.
Can I ask you a question on this? So the language models that you train, are they based on the previous conversations?
Of course, you actually train them. All of this thing has to be trained on the best and not so best to be able to come up with what the right approach should be. And of course, as being a generative AI, it's actually creating its own knowledge now. All right, finally, for AI and digital health to be adopted by hospitals and health systems, there's a cost to it, right? Yes, you actually get a benefit in terms of reduced costs. It has to fit into the clinical workflow in order to get scaled. But on the patient side, for it to get adopted, it really needs to address the engagement, the ability for patients to get a motivational support or be individualized to their particular needs and create a peer network. I mean, those are some of the key elements that go towards adoption. Thank you for listening to me.
Thank you. Like we promised, saving the best for the last. So Aman, before I go over to Dr. Malik first, so there's in the Air Force we use for every mission, there's a thing called ORM, Operational Risk Management. I think the risk factors that you're talking about, that's sort of similar before you even go take a flight. A day before, I fly for the Civil Air Patrol, which is part of the US Air Force. And the night before, I have to do an ORM analysis before I go even show up at the airport.
Aman, excellent talk. You have come a long way.
So we started together in a career and we have done wonderfully well. A couple of comments and a couple of questions. Quickly, first of all, I think as data...
Achinta, keep your mic closer.
Chris, thank you. As the data pool gets bigger and bigger, generative AI is going to get better. But I'm surprised that UPMC data is better than the NISQIP data. Could you explain why, from a single center data, which is significant, but not as large as the NISQIP data? So why do you think your data is better? Is probably the questioning so that your machine learning trend is better? Or your NLP you developed is better? What do you think that's the question number one?
So that's a great question, right? So first of all, we are better with our data. So NISQIP, that just shows the gap that exists, right? So NISQIP, while it's meant to be used across all institutions, it'll never be able to replicate our own environment, right? So that's why our results are better for our patient. That's one. Certainly the methodology that we used was better than, NISQIP's traditional model was based on regression analysis, and we've used a type of machine learning methodology and extracted far more features that exist in NISQIP. So that's the other one. And we have a 42 hospital system, right? It's got rural hospitals, community hospitals, and tertiary care hospitals. So it is actually a representation of ecosystem of the country itself.
The second question, I was quite surprised to see that the surgical outcomes have not improved. So I'm putting on my CEO hat and we keep fighting with payers. Is it because there's a push towards pushing patients out faster from the hospitals in the US to benefit the insurance company? Is that the reason?
So that may be that's possibly one of the reasons, right? So we are, when you look at, so when you look at data in terms of outcomes, right? Compare length of stay today as compared to 10 years ago or 20 years ago, and the length of stay actually hasn't changed. That doesn't mean actually improvement's not been made. What it means is that more and more sicker patients are actually being in the hospital. The ones that are actually healthier actually move to the ASCs.
So that's excellent answer.
But you still need to actually pay for it as a CEO.
So in my assessment for the last 48 hours, MAMC is leading right now. So.
We always have.
So.
Krish Rajan, I'm a vascular surgeon from New York. Actually, my natural intelligence was amazed with your artificial intelligence. My question is actually a little specific, but maybe you have a very elaborate answer. One of my concern about AI is the adversarial machine learning and the AI hallucinations. Now, these two could potentially offset all the goodness it can bring into healthcare, especially with clinical-patient relationship. So I would like you to help me. How do you see these two issues, the AI hallucination, the adversarial machine learning? The second aspect of my concern, which is very big concern, is the underwriting of insurances. In general, do not take the positiveness of AI to help people as much as make profit. So if somebody knows I'm going to die in 2 days, AI is as good at to diagnose that, the insurance company is going to say, why don't you kill him today? Right? That's how underwriting works. That's how profit works. Help me a little bit, you seem very insightful, for my human intelligence to understand how the artificial intelligence doesn't kill the humanity in clinical medicine.
That's a great question. I think AI is not perfect. I think all institutions that are incorporating AI, they're setting up AI governance groups, right? Because it's a multiple lens views that one needs to consider, right? So it's not just about increasing efficiency and automation, which AI can do, but it's a trade-off that you might have to take. And it does need the ethicists, the physicians and the nurses and patients representatives to be able to say, is that the right course and the right time for those patients? So again, the field of AI is sort of still maturing in how it needs to be incorporated. And I work fairly closely with the FDA on this. And the reason FDA hasn't actually created very clear guidelines is because of that reason, right? So we still don't know where we still don't have the full maturity to understand some of these things, what the impact would be. But like everything else, it's a question of time. We'll get there. There are biases that exist, right? So the data that you saw, and then one of the Harvard Business students earlier on in the last talk, or maybe you mentioned, and rightly so, that if it doesn't represent this, let's say, South Indian ethnicity or the black population over here, that's how the model is going to get trained, right? So we need to be understanding of the biases. So AI is only as good as how you frame that question, and that's what it should be used for. So there's a lot more to be done, and that's why I think we are focusing a lot more on the operational efficiencies and so forth as compared to actual clinical decision making.
That was a very fascinating talk, particularly for physicians of my age. And I think from the last question, I thought...
Do you have a smartphone?
Yes.
There you go.
I don't use it as well. Okay, but I was just, for the last question, instead of the pharmacy providing a 90-day supply of medication, they would only have to provide a 2-day supply of medication. And I guess that would be considered a savings. Okay, coming back to looking at this data, if there is failings by the physician and is identified by the system, does it cause legal exposure? And so I think I'll just have a couple of other things that I think about. Then there'll be a 2-tier system or a 4-tier system where different hospitals and systems and physicians and workers with different levels of understanding of the system, how is all this going to be integrated? Because I still have patients who come to me who still cannot get into their charts, do not want to connect to the systems, and they are the most needy patients that we have.
So great comments and thoughts, right? And they're all appropriate. Realize that this is AI, and AI has existed for the last 40 years. It's just that it's getting incorporated into healthcare more recently. It's getting mature. So some of those answers will come with time, right? So how do you integrate that across all physicians? There's some specialties like radiology and others have embedded that in their clinical practice a lot more as compared to the others, pathology, so forth, imaging-based specialties, and some of the examples that I shared as well. Many schools, medical schools, are starting training in AI. Now, there's a debate, right? That should physicians be experts in AI to be able to deal with AI in healthcare in the future? And there are different models that have been proposed, right? And that's applicable for our clinical. Not everybody is a cardiologist. Not everybody is an oncologist, right? But yet you know enough about other specialties in medicine to know whom to go to. Perhaps AI training and adoption would take that particular model. And many sort of progressive programs are building AI fellowships and AI training programs. So yes, the question is that the ones who are practicing now and don't want to, I would say there would be a time that they may not be as competitive as the ones who are actually using some AI methodology. It's just like, the people said they're never going to use the EMR, but everybody uses
So
the
actually,
EMR.
I was going to just say that we as physicians missed the boat in leading the EMR movement. And now look at where we are. Companies like Epic and Allscripts and all those companies, they tell us what to do. This EMR is a bunch of engineers sitting together, came up with something, and they impose it on you. You have to do things their way, not the way a physician or a surgeon or an anesthesiologist thinks. We are at the ground level of healthcare AI. This is one of the motivations why I wanted to be involved in this conference, frankly, because this is our chance to get things straight from the foundation up. The machine is going to learn what the data it is fed. I mean, we talk about AI and different things, but if you look at AI, AI could be different more like machine learning, but generative AI, and ultimately we wanted to get to that level where it's going to predict the example that you gave you're going to die in 2 days. How is it going to get that? Unless it has good data, it's not going to get there. So I think it behooves us as clinicians to be aware of the things that are happening in this realm so that we can be ready for what's happening. Thanks, Aman, for this wonderful presentation.
Thank you. Thank you all.
Thank you for being here and for giving this overview. Earlier you said that there is a lot of burnout with physicians, so AI right now, as it's being used in the research context, still requires physicians to do something, and you're already burnt out, so that seems like a hard thing to ask, as you said. What are other use cases that you see physicians actually wanting to use and actually wanting to put in the time to do versus use cases that you mentioned earlier are seen as like, I don't have time to do this, this is taking away from what I think is more important?
Great question, right? So, first of all, I think one of the single most important discoveries in clinical practice has been in AI. It's really platforms that are converting ambient listening, dialogue, and that's again uses AI into notes, right? So that's saved physicians 2 hours every day in doing so, and they're just getting better. I showed you an example of a surgical consent. That thing can actually be just a conversation between the patients while the patient's driving to the clinic, talking to a chatbot, and actually getting a diagnosis. So the physician having a diagnosis or a presumptive diagnosis before the patient shows up. There's enough knowledge that exists in there. So certainly addresses the barrier. The other aspect is on the research. I know you've asked a couple of questions on research. There are actually platforms that now are being developed, fairly mature. They will essentially write your entire paper and your entire grant over here. They'll actually do that. They'll ping the UK Biobank and they'll pick up data from your side. They'll actually make the graphs for you, and leaving aside your signatures, which you have to do yourself to NIH, they'll actually do the entire thing for you.
Thank you.
Hi, my name is Dr. Sandeep Parekh. I'm the internist. Don't take that I'm against the AI, but it looks like the clinical medicine is going down, 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 and the machine is taking over everything for our daily living. So will we be called the AI doctor, like primary care doctor, or the AI surgeon?
I don't think that physicians are going away. I think physicians will always, FDA is going to regulate AI as it regulates hospital beds, okay?
And is it a dollar game all the time?
It's not a dollar game. I don't think so. I think it's a convergence of technology and knowledge, and it's there to enable physicians. Yes, there's money to be made, so that's part of every innovation that's occurred in the world thus far. But again, it's also improving practices, right? There used to be a practice of bloodletting. Everybody thought that bloodletting was good at one time.
I have a comment on that. I mean, ultimately, whether we like it or not.
I understand. I told you I'm not against AI. But this is a discussion.
Yeah. We do home care. We use Abridge and then deep scribe all the time. Like you said, it's already in practice. So our nurse practitioners go and then record, and then the entire conversation turns into notes. That's just a small background. But the reason I'm talking now, like whether we like it or not, this is happening, right? Whether we want to be on the good side or bad side. Just like the cyber criminals, there are cyber police, right? And then without we being physicians in the game, the chances of that AI killing someone is high.
Alrighty. Yeah, so exactly, that was the point I was making. We do have to wrap it up, and Aman is going to be here, so we have more questions for him later on. Thank you very much, Aman. I'm sorry, we have to wrap it up. Thank you.